Hey everyone, and welcome to Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people like you who are doing great things in the world that I think you should know about. My guest today is Dr. Peter Rogers. He was on the show before, and you guys just did not want him to sign off. He was so interesting. He has an amazing YouTube channel. He's a big fan of Dr. McDougall, and he's just so knowledgeable about the science. I really encourage you to follow him on YouTube. I will provide that link in the chat and in the show notes. And by popular demand, he's back today, and he's going to be talking about atherosclerosis, hypertension, and diabetes. Please welcome back Dr. Peter Rogers. So nice to see you again.
Hi.
Hi. The floor is yours.
Oh, okay. Okay, well, great. Today we're going to talk about atherosclerosis and then hypertension and then some diabetes. They all kind of go together. Okay, I got to go to my slides now. Oh, and first of all, I wanted to say Happy Mother's Day. Chef AJ is the mother of the vegan community. She's
thank you.
The best nutrition weight loss website in the world. So I just want to congratulate her and thank her. So happy Mother's Day, Chef AJ.
Thank you. That's so pretty.
Also, I want to share with you, I had some thoughts about the Kempner weight loss program and, some of your ideas about weight loss. So I was reading about Kempner, and some interesting things were he had all the patients in the morning go for a weigh-in. It's kind of reminded me of wrestling. They all step on the scale, and it's public in front of each other, which is kind of a motivator because you got to get on that scale every day in front of all the other persons at the Rice House. They would have their blood pressures and stuff posted on the wall. They had persons who'd lost 100 pounds as like the Celebrity Centenarian Club. So I thought that was pretty interesting. And they obviously made a lot of tremendous weight loss and, and some health improvements that were wonderful. But I also noticed some problems. With the Kempner program, a lot of the patients, when they would go home, they would have a lack of follow-up and they would often relapse and regain their weight. Kempner started out a lot with the severe hypertension patients and a lot of kidney failure patients, and then he became more and more of a weight loss program. And so I think the rice diet worked fantastic. There's a lot of very interesting things about it, but the monotony of the diet, the lack of variety was part of what made it hard for the patients to continue with it. And I think, you've done a fantastic job giving patients some variety of things to eat, which helps them to enjoy it more and to work on making it taste better. Kempner would just say, do it, it works. And, he was incredible motivator in that in one sense, but on the other hand, that was kind of difficult for patients, especially when they went back to their homes. The lack of education, there wasn't a strong push to educate patients. And I think that's very necessary because your behavior follows your beliefs. And if you, believe in the nutrition that you're eating, it's easy to stick with it. You're not tempted by, some junk food because it's not good for you. You don't want that. And so some type of outpatient follow-up, in a sense, a community of weight loss and nutritional education is very helpful to patients. And so those are some advantages, I think, the way you're doing things here. And so I think that's good. And also, here's the thing, too. A lot of people tell me, I got no time to read. You know what? Everybody's got a bathroom, okay? You just put a table in the bathroom right there. And, number 2 is textbook time. Number 1 is paperback time. I read at least a book a week that way. An audiobook in the car, I like to read when I'm walking around. Okay. And also, by the way, you might find this interesting. As a way to study, I developed this idea. I heard this biography of Mozart, and he said, I think it only fitting to write while shitting. And I thought, well, gosh, I could read while doing that, And then I saw the Monty Python skit where they said, every sperm is sacred. And I said, gosh, you know what? Every void is sacred. I'm going to read a paperback. And so I don't get out of that bathroom unless I read at least one page. Okay, a quick little tour of some epidemiology I think would be helpful is right here. We're located now there's Arizona, and here's northern Mexico in the Sierra Madre Mountains with Copper Canyon. And that's where the Tarahumara live. And the Tarahumara used to be geographically more connected with the Pima community. After 1848, the Pima went into the area that is now Arizona. And they sort of over the years adopted a standard American diet, high in fat, oils, processed food, and they got a lot of problems. Whereas the Tarahumara has stuck with their ways. They don't even have cars. They just run around a lot. And a lot of them are farmers and whatnot, and they're real healthy. So kind of the point I'm making, this is about as good as it gets for epidemiology comparison studies. The Pima have severe problems with obesity, And if a person carries on, a poor diet for a couple of decades, they end up starting to need surgeries, and they end up with open heart surgery called a CABG, coronary artery bypass graft. Right upper quadrant is typical gallbladder surgery. Right lower quadrant, typical appendicitis. Person gets appendicitis if they're not eating enough plant foods because the plants have fiber. Fiber maintains the water in the stool. It liquefies the stool, so it'll be liquid on the right side of the colon, and therefore it will not form solid stool balls called appendicoliths. And an appendicolith is like a rock in the appendix, and then it blocks the mucus glands distal to it that secrete and try to communicate with the cecum, and then you can get stretching in the appendix, it bursts, appendicitis. In addition, they'll often get diverticulitis, straining at the stool, end up with a sigmoid resection for diverticulitis. Lots of amputation, diabetes, most common cause. And then in comparison, the Tarahumara are the world famous ultramarathon runners. So there's quite a difference. The Tarahumara are typically eating a diet of corn and beans and squash. They occasionally eat meat, but not much. And that also sometimes comes up. No completely traditional native population never eats meat. But I think for persons living in America, most of us have had some dietary problems in the past. We ate too much meat or junk food and stuff. So in a sense, we're trying to heal ourselves. And that's why I'm a big believer in 100% plant-based. I recommend no animal products. But anyways, I think it's a great contrast, the Tarahumara and their incredible endurance, and in comparison with the Pima, who've got a lot of health problems. And by the way, we got average total cholesterol in the Tarahumara is 136, average triglycerides 115. So that's pretty interesting. Okay, the next thing is sort of where am I going with all this? In terms of nutrition, I just drew this curve. Basically, if a person keeps having the bad nutritional habits, by the time they start getting in their 50s, they end up with all kinds of medical problems, and a lot of times much sooner than that. So one really needs to get their act together. The sooner the better, especially, you notice how everybody looks good to about 35 years of age. And that's because the body is burning through its reserve. So you want to keep that reserve as best you can. But after 35, if a person does not have good health and nutrition habits, they start aging really rapidly. Like cigarettes is the worst. I mean, I've seen girls in their 20s, they smoke and they look like they're almost 50. And anyway, some people say, well, I'm going to go lacto, ovo, or pesco vegetarian. And, that's better than eating the SAD diet, but you delay things about 10 years, but you still end up real sick. And then I kind of joke that the whole food, low sodium, low fat are kind of the health aristocrats or the healthiest people. Okay, a little bit of epidemiology here. This here is the Yanomamo. The Yanomamo live in the junction of Brazil and Venezuela in the Amazon jungle. And they don't add any salt to their food. They eat a predominantly plant-based diet. And epidemiology is a fantastic way to, confirm something you hear is correct in health information. They've checked their blood pressure through all the different age groups, and they don't have any hypertension, virtually never get hypertension. They don't add any salt to their food. It's been found they eat typically about 200 milligrams of salt per day. So they're a good epidemiology example. And that's one of the things you're going to see. It's not like a close match, between high salt diet, low salt diet of 5-4, or, a plant-based diet and a SAD diet. No, it's like 100-0. Okay. They don't have hypertension. Whereas persons eating a poor diet, they're almost all going to get hypertension by the time they're 60 or 70. Okay. It's almost like erectile dysfunction, about 40% at 40, 50% at 50, 60% at 60. It's about that. Okay. A little more epidemiology. The population in Kenya and Africa, they also eat a diet primarily of fruits, vegetables, and starches. Normal blood pressure, their blood pressure stays normal for life, with an average in their 60s of about 110/70. They eat a lot of cornmeal. And so again, like the Tarahumara, eating a lot of corn, a starch, incredible runners. They're world famous for winning all kinds of incredible middle and long distance running competitions. Okay, here's another kind of going around the world here with this epidemiology. We'll end back up in the States in just a moment here. Looking at epidemiology was also very interesting. For example, Roy Swank saw the data coming out of Norway that the high dairy population consuming a lot of saturated fat had much worse and more frequent multiple sclerosis. In addition, there was inspiring data came out of the rationing studies from World War II. Ansel Keys had looked at that. Lester Morrison, the cardiologist who did one of the first controlled studies of diet reduction of lipid for atherosclerotic coronary artery disease, and also Nathan Pritikin, of course, they saw that dropping that intake of the saturated fat to dairy caused a dramatic drop in cardiovascular mortality. There's also data that came out of England. And so that was very useful. So it was more important than the stress, so to speak, was the diet was more important than stress. And that turns out to be the case. Diet's more important than stress, even though stress is important, and exercise helps, but diet's more important. And then here's one in green. I wrote on the slide. I found out it's better to type, but I couldn't really change this one. A little more epidemiology is going to Finland. Finland, they had the same good result with rationing for health in World War II, but then afterwards, Finland had the highest cardiovascular mortality in the world going into the 1970s. And there was a guy by the name of Pekka Puska, was the physician in Karelia, that's a county area in Finland, in charge of the project called the Karelia Project in Finland. And basically, he did multiple things to help these patients. He stopped their tobacco, got them to stop tobacco, decrease their meat and dairy, eat more frozen berries all year round, but instead of just eating them one part of the year seasonal. The wives would often do the cooking, and he got them motivated, so they keep their husbands alive, taught them nutrition, reduce their sodium intake, and they had an 84% cardiovascular mortality decrease in Finland. So that's an incredible number, 84% decrease in cardiovascular mortality. So the point I'm saying is, if the entire country of Finland could do it, especially Karelia, that means any individual could do it. So it's very much possible to dramatically improve your health. Okay, just a little more epidemiology here. Okinawa, they had about 5 times as many centenarians as the United States when you go back around the 1970s, and that's when they were still eating a predominantly sweet potato diet. And it comes out to about 80-10-10 diet. The longevity around that time was about 78 years for the men, 86 for women, which is fantastic. It's one of the best in the world. It was better than the rest of Japan. Japan, despite smoking a lot of cigarettes, they were relatively healthy, and they had a lifespan of about 75 for the men, 80 for the women. Women tend to have about 5 or more years longer lives than men. Another thing that's really interesting was the Japanese and the Papua New Guinea. They smoke a lot of cigarettes, but they don't have that much lung cancer. And the relevance being the combination of the hyperlipidemia from a high-fat diet combined with the carcinogen of this tobacco smoking, as well as the hypoxia by the carbon monoxide, which is present in cigarettes, that really ups the incidence of cancer. So cancer is not just tobacco. That's an important point. Average California person in 1985, men about 74 years of age, women about 79.6. And then let's see, then I had it that, then what I wanted to do is compare that with the Loma Linda vegetarians, the one who ate meat less than once a month and had relatively good health habits. They have the highest recorded longevity for any population. So this is kind of good to know. It's sort of the benchmark, with men living 85 years of age and women living an average of 88.6 years of age. And actually, Dr. McDougall had worked with that population, and he said a lot of the persons included in that cohort were really not as healthy as one might guess from what's being described here. So he feels that, the potential average age of a person with good health habits could be more than that. Seems reasonable to me from what I've read, maybe I'm guessing about 92 years of age is probably, if you do everything right, all around all the health habits. Okay, yeah, and then, these arrows on here are just to show the migration studies, because some people say, oh, well, this or that, it's genetic. And by the way, I got Okinawa, I got it kind of shaped, and it kind of looks like that, one of the islands, like a sweet potato. The Japanese, as they migrated to Hawaii and then to California and took on more and more Western dietary habits of meat and oils and dairy, their health progressively declined, more atherosclerosis, hypertension, diabetes, coronary artery disease, and cancer. Okay, why study atherosclerosis? Most common cause of death. And that's most likely reason to die. And it's easy to learn about it. It's easy to avoid it. And then the other thing that's good about it is when you avoid the risk factors for coronary artery atherosclerosis, you pretty much avoid most of the risk factors for most other chronic diseases. So you make yourself a lot healthier overall, because most of the risk factors for all the common causes of death, they're all the same, most of them, for kidney failure, dementia, diabetes, hypertension. And most of them are food. There's other things, of course. Avoid tobacco, avoid alcohol, try not to live in a place with too much air pollution, get your sunshine. Okay, coronary artery disease, is it reversible? Yeah, it's reversible, and this has been proven multiple times over. Kempner was reversing EKGs back in the 1930s and 40s. Pritikin had similar results on his population of patients. They've shown it in monkeys, rhesus monkeys, and other studies. They just markedly reduced the lipid, and patients will routinely have partial reversal, sometimes complete, of their atherosclerosis. William Roberts, C. Roberts, he's a pathologist, very interesting, probably the best cardiac pathologist ever. And he said from his research and his experience, anytime you feed a herbivore a high-fat diet, they always get atherosclerosis, all of them. Okay, so any human, we basically have a physiology to match a herbivore. Everybody who eats high-fat diets, they're going to end up getting atherosclerosis. You know, it's a variable when they're going to present with impotence and coronary artery disease and stroke and all that, and hypertension, but it's going to happen. It's inevitable. The other guy who's really good with atherosclerosis research is Gregory Sloop. We're going to come back to these guys, but pathologists, I've been interested in atherosclerosis for about 25 years. And I can tell you, these pathologists, I think they're the ones who know the most about atherosclerosis because they're looking at it under a microscope. And they're looking at it at autopsy too. Okay, Dean Ornish did fantastic study showing reversal of coronary artery disease on SPECT scans. Caldwell Esselstyn had some patients reverse on cardiac cath and had an absence of recurrent events, 99.4% of his patients out of 198. It's from the Journal of Family Practice, 2014, with no recurrent coronary artery events. Those are incredible results. Okay, this is just a picture from Kempner. You know, I read through all the Kempner stuff. I went to the drmcdougall.com site and I read through Pritikin's legacy book, published in 1988 by his wife, posthumous. And I also read through the Dr. Kempner scientific publications there. And Kempner's work in particular is very unusual. It's incredible. All these page after page after page of chest x-rays that have normalized. So we're looking here at a comparison of two chest x-rays. We've got the entire side-to-side width of the chest standardized at 36 centimeters. And patient after patient, he saw an improvement in their heart size. Now, why does the heart size improve? You know, because you're correcting for the side-to-side ratio, that's helpful. It could be a partial reversal of congestive heart failure. Sometimes also, I think the patients also have what I would call a Pickwick syndrome. Pickwick syndrome is obesity hypoventilation syndrome, whereby the obesity of the abdomen is pushing up the diaphragm. And so that makes them, you know, a little more short of breath with exercise, going up the stairs, fat person huffing and puffing, because they can't lower their diaphragm enough to more fully oxygenate the lungs. But even still, pretty impressive stuff. We talked about the EKG reversals. Now, this is a diagram of a coronary artery plaque. And so what's interesting about it is atherosclerotic plaque, by the way, it begins as a blood clot. I know everybody thinks cholesterol, lipid. Yes, of course, that's an important part of atherosclerosis. But trust me, if you study it extensively, you'll see atherosclerosis begins as a blood clot. And then, just like a blood clot anywhere else in the body, think, for example, of a hematoma. The immune system cells come into the hematoma and they gradually reabsorb it and they leave a scar. So that's what happens with initial atherosclerotic clot. So the lipid within there, the lipid core it's called, that can be reabsorbed. The necrotic material called the necrotic core, that can be reabsorbed. I've got the letter F here for fibrous tissue. And there's really two types of fibrous tissue. There's the more cellular, initially forming fibrous tissue. And then there's the more chronic, fibrotic, hard scar, collagenous tissue. And so some of the cellular fibrous tissue can be partially reversed, but certainly, like we just said, the lipid, the necrotic debris, that can all be reabsorbed. So that plaque can shrink. And then the question arises, why do patients improve so much and so rapidly? And that's for a couple of reasons. When you improve your diet, when you go from a plant-based, when you go from a high meat processed food diet, which tends to be high in sodium, and low in potassium and magnesium, when you go to the plant-based diet, there's just naturally a lot of magnesium and potassium in plants and relatively little sodium. Those are vasodilators. Sodium is a vasoconstrictor. So you're going to start opening up your arteries because of that. The nitrates in the greens also are precursors for making nitric oxide, the major vasodilator released by the arterial lining endothelium. So that's going to start opening up blood flow as well. So that's why people can really improve a lot in just a couple of days. And then with more time going by, they'll even get better. Okay. Oh, by the way, these purple cells here are endothelial precursor cells showing they cover up the plaque. So we're going to talk about how the atherosclerotic plaque forms. We'll get to that. I have another slide of that, but that's an interesting thing. They're circulating endothelial precursor cells. Okay, the first concept here with atherosclerosis is what is called the Wing-Kessel effect. A Wing-Kessel is that thing like when you have a fireplace and you want to blow some air on the kindling to start the fire. And so what that means is when the heart contracts, that's called systole. The blood is pushed into the ascending thoracic aorta. The ascending thoracic aorta then stretches outward and it has a lot of elastic fibers. Then when the heart relaxes, that's called diastole, the elastic fibers recall inwards, and that maintains good blood flow during diastole. So that's the second number when you look at a blood pressure. So this aorta elastic recall is very important for generating blood flow during diastole. And you can think of it as a second heart. And here's the key point. Those elastic fibers cannot be replaced after maturity, let's say after about 22 years of age. So if a person has a lot of hypertension for decades, they will wear out all those elastic fibers and they will lose their Windkessel effect. And then it'll be harder for them to get their blood pressure back down to what it was when they were 20. So the longer a person has hypertension, the more they overstretch their elastic fibers, as well as the more atherosclerosis accumulates on their arteries and calcifies them. I've seen lots of people with a lot of atherosclerosis risk factors, and these are typically patients in their 60s or 70s or 80s who have not had good habits or who've been smokers as well, and their entire aorta is diffusely calcified. So they have almost zero elastic recoil, meaning that they're going to have decreased diastolic flow. The coronary arteries mainly perfuse during diastole when the heart muscles relax. So if you don't got good diastolic flow, you have to crank up the systolic flow. That's also why you don't see that much diastolic hypertension after 50, because a lot of these patients, they don't have good elastic recoil. Okay, here's a typical blood pressure for normal. We're just going to give as an example, 110 over 70. Pulse pressure is the difference between the top number, systolic, and the bottom number, diastolic. So that'd be a good pulse pressure of 40. Now here's somebody with severe hypertension, 200 over 100, and a big wide pulse pressure of 100, subtracting 100 from 200. So that's a bad blood pressure. Okay. Here's just some examples of numbers. Dr. McDougall likes to have a persistent systolic pressure over 160 measured at home before he'll treat. So that's a separate thing. And these are just some numbers so you have a general familiarity with them. When a baby's born, they're 90 over 60. And in populations where they don't eat a salt diet, they don't really tend to change too much. Maybe get up to around 115 over 70, but not that much. So also what I'm saying here and kind of why I went through that epidemiology is to show that it's not inevitable. Old people can be really healthy and energetic and full of life and energy. You don't have to be fat, sick, and cognitively impaired. Okay. Here's something I wanted to show you. This is my wrestling coach from college at Stanford. This is Mark Schultz. This is him wrestling against Iowa when he was in college, winning the national championship over Ed Bannock. Ed Bannock was like a two-time national champ. Everybody thought Bannock was going to win, but Mark Schultz won. It was an incredible match, one of the best NCAA wrestling matches ever. Okay, and then the reason why I'm showing it, and he was a great coach to me. He really helped me a lot. That's his brother Dave. He was also world and Olympic champion. He was featured in, that movie, the Foxcatcher movie. But what I also want to say about Schultz, he got hypertension. He usually doesn't talk to me about this stuff, but he asked my advice, said, switch to eating plant-based. Very rapidly, his blood pressure went down from 160 over 110. He told me to tell people he's real happy and proud of this. His blood pressure went from 160 over 110 down to 115 over 75. So that's just one typical example. Okay, why is hypertension such a big deal? Hypertension is kind of the gateway disease to other problems. Again, it's typically asymptomatic initially, and it's progressively causing injury to the arteries. We're going to talk about how that happens, but it's one of those things you want to get it under control the sooner the better, because you're going to be losing those elastic fibers in the aorta. You're also going to develop what's called hyaline sclerosis of the smaller arteries as well, and they're going to lose some of their elasticity, their flexibility. And the more, arteries are not just like plumbing pipes that are fixed in their diameter. They have some ability to dynamically change their diameter in response to conditions. Like if you're exercising, you need more blood flow. And that is progressively lost over time if a person doesn't reverse their health habits. Okay, here is one thing we talked about, the mouse. And to me, hypertension is sort of the quintessential prototype disease of the mouse. So the mouse stuff comes from the research of a guy by the name Jack Delatorre. He would take mice and he would tie off their carotid artery. And when he tied off the carotid artery, they then would the mouse would typically become demented about 2 months later. And then they would do autopsy on the mice pretty soon after that. And what they found was there usually was not a stroke. There was just an atrophic brain on the same side as they tied off the carotid artery. So the point is, chronic decrease in blood flow leads to a gradual progressive loss of brain cells. So when a brain cell dies slowly. It recycles itself. That's called apoptosis. And it's beneficial to the animal because they can reuse the chemicals within that individual cell. You look at a brain MRI, you can't see anything except for atrophy, a shrunken brain on that side. But the point I'm saying, think about it. If the blood pressure is way too high, they're at risk to bleed into the brain. If the blood pressure is too low, then they're at risk for underperfusion of the brain. So a lot of people, they're all afraid of a high pressure. I would recommend be afraid of a low pressure being too low. You know, it's a little bit like diabetes. Everybody talks about high blood glucose. Well, low blood glucose is more dangerous. You want to stay in the healthy range. And the body's got lots of sensors to maintain a good blood pressure and a good blood glucose. Just feed it what, you know, it's best off with a low fat, low sodium plant-based diet, and the body's sensors will tend to control things well. So you see my point. And you can get yourself into what I call mouse equivalents very easily. AFib. Why do they have an increased risk of dementia? It's not necessarily just because they throw an embolus to the brain and have a big stroke. More often than not, they're losing that atrial kick, 25% of cardiac filling, and they're chronically underperfusing their brains. Congestive heart failure, under-pressured heart, and they're not perfusing their brain adequately, leads to cognitive decline. Sleep apnea, hypoxia. Some of these patients have really low oxygen saturations overnight. Diabetics, it used to be that they just do 3 finger sticks a day. They have no idea what their sugar is at night. Now, when they put these continuous glucose monitors on, they're finding out a lot of them are dropping their blood glucose at night into the hypoglycemic ranges, you know, like in the 50s or something. And that's dangerous. The brain's hypoglycemic because you're at risk to lose brain neurons from that. So the point I'm saying is this concept of vascular disease related to hypertension and atherosclerosis being tied into dementia, it's essential. I look at brains every day, and I can tell you, I think this is by far the most common cause of dementia is these combinations of impaired cerebral blood flow. And sometimes that's superimposed on increased metabolic demand, whereby the person is increasing the metabolic demand of the brain. For example, things with cigarettes and things like that. Okay, one thing briefly on sleep apnea. Like I said, I've seen guys in their 30s dropping their oxygen saturations into the 60s overnight on these sleep studies. And so that's pretty risky stuff. One certainly has to be careful because, you know, they're at risk for, I've seen guys demented in their 40s. So, you know, if you have all good habits, you avoid all this stuff. So this guy's got a continuous positive airway pressure mass there. Okay, now we're going to get into a little more of the physiology of atherosclerosis. Peripheral smear, we'll see that it's by far the most common blood cells, red blood cells. So whatever's happening in the blood pretty much goes by the RBCs most of the time. Here's a test tube of a blood draw. You see the red blood cells sedimenting out at the bottom. That's the hematocrit. Usually, you know, let's say it's in the 40s there. White blood cell, the buffy coat, the plasma up above. And the higher the hematocrit, the thicker the blood. And that comes into play when you think about those Tour de France bicyclists who are taking that epoetin, which artificially increases the red blood cells. Some of them are having myocardial infarctions because they got their hematocrits too high. They're all in the 50s. And, you know, that might help them to ride a little faster when they're going up a hill. But when they're just laying around at their apartment, that thick blood can clot off their coronaries. Okay, next thing here is a picture of the spleen. Spleen's like the graveyard for the red blood cells. And what that means is as red blood cells get older, they typically are removed by the spleen at about 120 days. They become more stiff. And it's thought to be due to glycation of red blood cells. And when they go through the spleen sinusoids, it's like a filter mechanism. They're relatively small. A typical capillary is about 5 microns. The spleen will have sinusoids where the RBC will have to pass through about 3 or 4 microns. So, they will, the red blood cells will lyse and they'll be cleared by splenic macrophages. So that's an interesting thing. So what's the point of that as well? If somebody has their spleen removed, they're going to have a lot more stiff old RBCs floating around, and that's going to raise their blood pressure. And the converse of that is if a woman has a hysterectomy. Normally a hysterectomy for a woman is like a monthly therapeutic phlebotomy that lowers her hematocrit. In addition, the red blood cells, when they first come out of the bone marrow, they're more flexible because they're not so glycated. And so that's why women will tend to have significantly lower blood pressures. And that's also why a premenopausal woman almost never will have a myocardial infarction. So it's a big health advantage. Okay, here's just a picture showing that a red blood cell is about 7 microns in diameter. Capillary is about 5 microns. And because the capillary diameter is smaller than an RBC, the RBC normally has to deform a little bit, fold over on itself to pass through a capillary. And so what that means is, let's say a person chronically eats excessive amounts of saturated fat. Well, that's going to affect the percentage of saturated fats incorporated into the plasma membrane, the phospholipids of the plasma membrane of the red blood cells are going to be stiffer. That's also going to increase blood pressure. Okay, here's a graph showing the relationship between LDL cholesterol and blood viscosity. The higher the LDL cholesterol, the higher the blood viscosity, meaning the thicker the blood. The thicker the blood, that's a bad thing because it means that the blood is at increased risk to clot. It also means that when the blood becomes thick like a milkshake instead of thin like water, the heart's pumping pressure has to be increased to push that through the capillaries. So blood pressure goes up. And here's a picture of sort of like how it works. Red blood cells have a negative charge along their outer surface. That is called the zeta potential. And, blood banks for storing the blood transfusions, they're very well aware of this, okay? But a lot of people don't know this. It's not something that people routinely know in their studies of atherosclerosis and blood. So the RBCs repel each other because of their negative charge, but they're molecules that can overcome this. So LDL cholesterol is a bridging molecule that can overcome this. IgM antibodies are a bridging molecule that can overcome this. Fibrinogen is a clotting factor that can overcome this. And also uric acid can. So all of these things can make the red blood cells stick together. When they stick together like a stack of coins, that's called rouleau formation. It's like a French word. Here's a picture of a sialic acid. The way I think of a sialic acid, it's really just like a glucose molecule, and you stick a carboxylic acid on there. Carboxylic acid is deprotonated. That's where the negative charge comes from. It's not really a big deal. I mention it, though, just so you've heard of it, because you're going to sometimes hear about something called xenosialitis, and that's a meat-related inflammation due to the intestinal tract confusing the sialic acid residues on the outer surface of a cell, and that's called xenosialitis. We're not going to get into that, but having seen the sialic acid now, when you hear about xenosialitis, it'll make sense. Okay, there's a picture of the rouleau formation with the RBCs stuck together by the bridging molecules, and when they're all stuck together, it's going to be tough to go through that capillary. Okay, so here's the same picture a little bit bigger. And what does blood flow look like? You could hold out your hand, just look at your palm in front of you, and the two fingers in the middle, that's where the red blood cells are when they're flowing down a blood vessel. And just on the outside of them, that's the white blood cells. You can put your thumb, your other hand, your thumb on the other outside. That's where the plasma flows adjacent to the arterial wall. And that's a normal parabolic blood flow profile. It's also called laminar blood flow. That's good. That's how you want your blood to flow. And everything works optimal with those types of flow conditions. And now we're going to show what happens at bifurcations. At bifurcations, the blood hits the divider, the median divider. This right here is the external carotid artery and the internal carotid artery going up to the brain. And by the way, it's the same thing in the coronary arteries. There's actually far more bifurcation points in the coronary arteries. That's why in the carotid artery, you'll just typically form atherosclerosis at this one spot, at the origin of the internal carotid artery. Whereas in the coronary arteries, there's multiple locations with all these bifurcations where atherosclerosis tends to form. So when the blood hits the median divider, it then spirals off of that in turbulent flow, and some of the flow goes backwards. That's called retrograde flow. They're also called eddy currents. And these slow eddy currents are where clots tend to form. And there's things that will contribute to it. Remember how we talked about the big pulse pressure difference? When you got the real high systolic and the low diastolic, there's more time along the far wall. It always happens on the far wall here. I look at CT angiograms every day, and this is where the clot starts. Okay. And so people also will have a ability to repair these clots when they are initiated, depending on how well their immune system's working, depending on how many endothelial precursor stem cells they have. And they'll try to keep this clot under control. So if the blood is sticky for other reasons, due to diabetes, due to a high fat meal, all of those things increase the tendency of the blood to form a clot along this outer wall. So here's another drawing of it showing the clot along the outer wall. And endothelial dysfunction caused by diabetes also a major contributor to this. And so if they optimize all their habits, they'll often can reabsorb these. But if their habits are not good for their atherosclerosis risk factors, this will progress and eventually occlude the carotid artery. Carotid artery, severe stenoses and occlusions are pretty common. I see them all the time. Okay, a few thoughts on endothelial injury. High blood pressure is a major contributor to atherosclerosis. And how do we know that for sure? Because you don't see them in the veins. Veins are a low pressure system. They don't get atherosclerosis. You take that same vein and you put it onto the the heart with a coronary artery bypass graft, it'll get atherosclerosis. You take that same vein and you staple it into their arm for a dialysis, arteriovenous fistula, they'll get atherosclerosis into it. You look at the pulmonary arteries, that's also a low pressure circuit in comparison with the systemic arterial circuit, and they don't get atherosclerosis there unless they have pulmonary hypertension. Okay. And then some people might ask, well, how do you know endothelial precursor cells are really floating around in the blood and they're not just coming from the local tissue growing over the clot? Now they know it because they've done transplant studies and a lot of other research. Plus, you can get atherosclerosis plaque in a prosthetic dialysis graft, meaning that it has to come from a stem cell. There is no adjacent intima of endothelial cells to grow over it. Okay, here's a picture of endothelial cells showing that they're shaped like spindles with their long axis along the direction of the blood flow. And they've got little cilia-like mechanoreceptors, like hair cell receptors that can sense the direction of flow. And that's how they know if flow is abnormal, if it's unusually turbulent. The higher the blood pressure, the harder it smacks against that median divider and spills out into turbulent blood flow. Turbulent blood flow, when it's excessive, is not good because it activates the platelets, making them more prothrombotic. It can also be sensed, again, as injury of the endothelial cells. So they'll start to withdraw their antithrombotic cell surface molecules or antithrombotic glycocalyx and start to express more prothrombotic molecules on their cell surface. Okay, here's also a picture of an endothelial cell. And the main thing for our purpose is to be aware that nitric oxide is the most important thing to know about. And I went to this Caldwell Esselstyn, training session to meet him and whatnot out of the Cleveland Clinic. And he kept talking about nitric oxide. And I was like, well, what about this other thing? What about this other thing? And then he talked to me afterwards, one-on-one. He said, got to emphasize nitric oxide because if a person understands that, then they will do really well. And he says the other details, it doesn't necessarily help them. And I would agree. You just need to know nitric oxide is the thing to know. That's a major vasodilator. It also inhibits platelet aggregation. And that's the key thing to know. There's other stuff to it, like the endothelial cells have their own zeta potential with all the negative charges coming off that heparin sulfate. Okay, here's another atherosclerotic plaque. And I was also showing kind of like the time course of an atherosclerotic plaque. It starts out predominantly as a blood clot, and there's going to be LDL cholesterol in there helping to stick the RBCs together. But then gradually, as the macrophages and the other immune system cells come in there and the fibroblasts come in there to make fibrous tissue, it'll eventually shrink and become calcified. So typically we think of a calcified plaque as an old scar. And they're usually not going to do too much, an old scar. They're less likely to embolize. A big soft plaque is more likely to rupture into the lumen and spill out some thrombotic material or lipid material that can embolize distally and cause a stroke, or if it's in the carotid, or cause a myocardial infarction if it's in the heart. Okay, we'll talk a little bit about fats. We'll just go through a little nomenclature, not much, just to get some key points. So a fatty acid is a carboxylic acid. So here's a carboxylic acid. You've got a carbon with a double bond to an oxygen. That's a carbonyl group. And then you have an OH group here, a hydroxyl group. And anywhere you got an oxygen means it's polar, means that there's a charge on it, means that it's soluble in water. The remainder of the molecule, though, is all carbons and hydrogens. Carbons and hydrogens have about the same electronegativity, the same desire to pull onto an electron. So there's really now no noticeable charge about them, such that they are non-polar, non-charged. And that also is hydrophobic. So that's why, oil and water don't mix. So this is the oily part, so to speak, of the fatty acid, and this is the polar part. And the point I would make here too is these are amphipathic, meaning like an amphibian. An amphibian could live on water and on land. So the carboxylic component is more polar. Okay, so there's two components, and then the tail, the fatty acid tail, is carbons and hydrogens. That's more nonpolar, hydrophobic. But this ability to be two things at the same time, both polar and nonpolar, is why fatty acids can function like detergents, why they can cause leaky gut, and it'll also explain a lot about the transport systems in the body. Okay, so a MUFA means a monounsaturated fatty acid. A PUFA is a polyunsaturated fatty acid. So unsaturation, saturation means saturated with hydrogens. A carbon has any spot, we don't even draw the hydrogens because it's just understood anywhere there could be a hydrogen on it, a carbon binds to four things, it's always a hydrogen. So that's called saturated with hydrogens. We just say saturated fat, sat fat. Versus MUFA, monounsaturated fat, means that there's one double bond. And the typical MUFA is olive oil. But olive oil is not just one thing. It's predominantly a MUFA, but it is also contains some sat fat in a ballpark of 11%. It also contains some PUFA. All right. PUFA PUFA, polyunsaturated fatty acid. PUFA, the poly just means more than one double bond, 2 or more double bonds. And the ones that are useful to know about is linoleic acid. So C18 means C for carbons, 18 carbons, and then the colon, and then 2. The 2 represents 2 double bonds. And then the W is the same thing as an omega. It means that the counting is done from the methyl end of the fatty acid. And that's in comparison, like in organic chemistry, they'll count from the carbonyl carbon. But you don't want to do that because when fatty acids change in size, that'll confuse things. So you always want to count from the methyl end, and that's going to be labeled with a W or an omega, or even sometimes the letter N. Those are all the same thing to symbolize we're counting from the methyl end. So these are the omega-6 fats, is what they're most often referred to in nutritional jargon. The alpha-linolenic acid, that is a C18-3 with 3 double bonds, and that's W3, meaning that the double bond is at the 3rd carbon. So you just carbon number 1, carbon number 2, carbon number 3, double bond there. That's an omega-3. Carbon number 4, number 5, number 6, double bond there. That would be an omega-6. Okay, now here is a little bit of understanding about PUFAs. So a PUFA is a polyunsaturated fatty acid having more than one double bond. And I use the pink right here to indicate the double bonds. And the unique thing about the double bond here is that the hydrogen in between the double bonds has a special name. It's called the methylene bridge. So a carbon with 2 hydrogens on it is called a methylene group. And this is called the methylene bridge located between the double bonds. And the point is that these double bonds, they pull on the electrons. And because they're pulling on the electrons, that hydrogen is only held very weakly by carbon number 8 here. And what that means is other molecules can come around, especially things that contain oxygen, and they'll just pluck off that hydrogen, and that can initiate a cascade of reactions called lipid peroxidation. That's a super important concept, lipid peroxidation of PUFAs. Now, lipid peroxidation can happen in a MUFA, like olive oil, monounsaturated fatty acid, but it's much less common. It's much more common with the PUFAs. And this is part of why in the 1950s, there was a big push to reduce saturated fat after all the rationing data, the 7-country study by Ansel Keys and whatnot. So in the 1960s, they switched to using a lot of PUFAs, like especially all the different cooking oils. And what they found is it had no cardioprotective benefit. Even if the cholesterol was not raised as much, issues which I think are significantly due to PUFA lipid peroxidation and also blood sludge effects, there really was no noticeable significant improvement in atherosclerosis. Okay, and this is just showing the carboxyl end. That's also called the delta end. So if you see a delta in the writing of somebody writing about a fatty acid, that's what they're talking about. They're counting from that other end, but we don't want to do that. Okay, this is just a quick way to real quick make sense about these fatty acids. You don't have to do this unless you're interested in it, but I'll just show you a real fast way how I handle these so I can keep track of them in my mind real easily. So O for oleic, I just remember that's O for number 1, 1 double bond, and that's your typical olive oil, MUFA, monounsaturated fatty acid. And then linoleic acid, I remember LA, that's 2 letters. So it's got 2 double bonds. ALA, alpha linolenic acid, it's got 3 letters. ALA, 3 double bonds. For Iraq, I just remember ARAC, 4 letters, 4 double bonds. And then here is EPA, and that one's got a penta there, so it's going to have 5 double bonds. DHA, the H is for hexa, and hex means 6, so 6 double bonds. One of the points I'm making here is this icosapenta, EPA, and DHA, they got a lot of double bonds. I mean, they are the more double bonds, the more vulnerable fatty acid is to lipid peroxidation. So they're much higher risk to spoil. That's why they're going to be in an opaque container, and you got to put them in the fridge right away. And that's also why, me personally, I think they're overrated because I worry about them spoiling, undergoing lipid peroxidation. Okay, now here's some interesting stuff. This is a paper by Peter Kuo. Peter Kuo fed patients saturated fat. He was a cardiologist from Philadelphia, and he measured their blood lipids every 30 minutes. And these were a bunch of cardiac angina patients. So that's a rather bold thing to do. Took, forget the exact number. Let's say it was about 12 or something. And he had these cardiac angina patients, and he fed them high-fat meals. He had them in a observational setting, checked their blood lipids every 30 minutes. And he found that their blood lipids peaked at about 5 hours after a predominantly sat-fat meal. And that's right when they tended to get their chest pain, most frequent episodes of angina, most severe episodes of angina, correlating the high-fat meal with peak blood lipemia and peak symptoms of ischemia. Ischemia means decreased blood flow to tissue. So that was pretty convincing and pretty impressive stuff. And then the next study was done by a group of physicians, ophthalmologists, Meyer Friedman and Ray Rosennam, and they studied patients putting a microscope, 80-fold microscope over the patient's eye, and they could watch blood vessels occlude in real time. They also were curious about what's going on with these unsaturated fatty acids. And what they found was, by the way, with the peak lipemia from sat fat, it had cleared out of the blood by 9 hours, and it was pretty well gone by 8 hours. But with the unsaturated fat, this is feeding the patients the oils, that blood remained in a blood sludge, real thick mixture of fat and normal components for a prolonged amount of times, well past 9 hours. Even the researchers got tired. They wanted to go home. So what I'm trying to say is these oils have a tremendously negative effect on blood flow, and I recommend avoid those oils. When they fed the patients a high carbohydrate meal, we can see the green line down here below. There was no lipemia. Okay, there was no significant lipemia, and there was no anginal episodes. Okay, what makes blood thick? So we talked about some of the things. We talked about hysterectomy. And by the way, if women have a hysterectomy before the age of 35, they have a much increased risk of developing significant hypertension, congestive heart failure, early onset dementia. The Mayo Clinic did a study of about 2,000 patients. That's been shown to be the case. And I have seen that in my own personal experience. I look at a brain on a woman, she's cognitively impaired, demented in her 50s or 60s. I look for the usual risk factors. And if she has no risk factors I can find, then I check her surgical record, and I can tell you when I can't find any other risk factor, it's usually because she had a hysterectomy in her 20s or early 30s. And what will happen is she then becomes quite hypertensive after that. And a lot of times women aren't as afraid of atherosclerosis as a guy is. A guy starts seeing his friends becoming impotent, having myocardial infarctions and problems in their late 30s, early 40s, and 50s. And so he's scared. He knows, if he's with it, he's going to know something about atherosclerosis. Or a lot of times, a lady, if none of her girlfriends had a myocardial infarction before 50, she's not as worried about it. And some of them have really poor dietary habits, superimpose alcohol, smoking, and whatnot. And I've seen a lot of women who've had hysterectomies before 35 years of age, having strokes and having cognitive impairment at a relatively young age. So, because usually I look at a woman's brain in her 50s, it's clean. There's usually nothing. It's totally normal. So that's something that a lot of people don't know. All right. Sickle cell anemia is another good thing to talk about with regard to atherosclerosis. The point being is a child with sickle cell anemia, teenager, can have a myocardial infarction or a stroke, and they'll have normal cholesterol. So the point I'm making with that is you don't need high cholesterol to have coronary artery atherosclerosis and have a heart attack or stroke. Anything that makes the blood thrombotic will do it. And that's why those autoimmune diseases will do it. Like look at lupus, for example. They can have anti-cardiolipin antibody. We're going to talk about cardiolipin a little later in this talk. But being sedentary, your blood starts to aggregate a little bit. I think that's why when you go on a long car drive, after a couple hours, you get out of the car, everything's kind of stiff and awkward. I think it's because your blood's like gradually aggregating. You got to get those arteries to open up and that blood to start flowing well. And also being in the cold makes you slightly prothrombotic. That's why I like to be warm. I think that's why a lot of these people, they feel better moving south for retirement when they're warm. And I've also seen other patient populations doing a little bit better where it's warmer, maybe also because there's sunshine, more fruit available, more vitamin C, but I do think there's something to that. Okay, what else is interesting? Well, that's good coverage for that. I usually leave a little more detail on my slide, so if anybody really wants, they can go back and read all the details. Now we're going to talk about what's really happening with sodium and why do I prefer low sodium? There's a lot of stuff to know about sodium, but what I'll basically say here is every cell in your body has an energy system on its outer membrane called the plasma membrane, and it runs on these Kn ATPases. The first number is K, which represents potassium. That means kalium in Latin, okay, for potassium. And that will pump in 2 potassiums right here, okay? Over here, the N stands for natrium, and then Latin, that means sodium. So 3 sodiums are pumped out of the cell. So you can see you're pumping out 3 positive charges for every 2 positive charges pumped in. And because of that, you're going to accumulate a net negative charge inside the cell. A typical intracellular voltage across the plasma membrane is going to be negative 65 millivolts. You're also going to accumulate a gradient. You're going to accumulate 2 gradients with regard to the sodium. The sodium will be in higher concentration amounts outside the cell. So that's a concentration gradient, sometimes called a chemical gradient. In addition, because the inside of the cell is negatively charged and the sodium is positively charged, that means the sodium outside the cell really wants to come into the cell. Okay. So that strong desire of the sodium to come into the cell is like a water flowing down a diagonal hill to run a mill wheel. And by that I mean, for example, right here is how the cell pumps calcium out of its cytoplasm. So it brings in sodium that wants to come along its chemical gradient and its electrical gradient, and it then pumps out calcium in exchange. It's like spins like a mill wheel, and they call it the NACA exchanger. Na is the Na for sodium, Ka is for calcium. And that's a very fast, powerful pump for pumping out calcium. And that's a big deal because you can think of calcium as being like a light switch inside a cell. As soon as you raise your calcium inside the cell cytoplasm, in a muscle cell, that tells the cell to contract. In a brain neuron, that tells the cell to release its neurotransmitter or to fire an action potential. Okay, that's related to the mechanism for insulin and issues with regard to insulin secretion by the pancreas. We're not going to go into all that, but trust me, it's coupled to tons of things. It's coupled to management of protons. It's coupled to management of amino acids. So the bottom line is your cells really depend their energy system on that KN ATPase. And when you eat an excessive dietary amount of sodium, you will accumulate sodium in the cell. And the tissue has to maintain an exact balance of cations. Cations means positively charged ions. So the more sodium you eat, the more potassium you're going to urinate out of your body. So it's very important, the ratio of potassium to sodium. And normally if you're eating a plant-based diet, you get tons of potassium relative to sodium, like 10 to 1, 15 to 1. And our bodies are made for that purpose. We're really good at excreting out extra potassium. We're not as good as excreting out extra sodium. And so that's why we're not designed for this modern processed food diet where we've reversed the ancestral ratios of potassium to sodium. So we're designed to eat about 10 to 1, 15 to 1 ballpark potassium more than sodium. But nowadays with people eating processed food, they're often eating 15 times as much sodium instead of potassium, and that's not good. And then that will decrease their ability to rapidly pump calcium out of their cell cytoplasm, meaning that, and this is a key point here, their cell intracytoplasmic calcium will be too high inside of their smooth muscle cells, which line the arteries and make the arteries contract and constrict. So they'll have high tone, high vasomotor tone in their arteries. Their arteries are contracted, they're narrowed. When you pump blood through a narrowed system, pressure has to go up. So that is the key mechanism to understand for sodium, excess dietary sodium related hypertension. Okay, this is just showing some concentrations that the sodium is about 140 in the extracellular matrix relative to its inside the cell, only 14. So that's the chemical concentration gradient we talked about. With potassium, it's the opposite. Most of the potassium is inside the cell. With calcium, it's astronomically higher outside the cell, 10,000 times higher. Okay. And again, that's like an on-off switch for cell function. By the way, in your brain cells, literally 2/3 of your energy, 65% of it is used to run that KN ATPase. I'm telling you, your brain depends upon that. And that's another reason why I also recommend that a person should try to be the best you can be. Try to be as healthy as you can be. Try to optimize your cognitive function, because you'll fix a bunch of little mistakes along the way and everything will be for the best. Versus if you're just kind of lackadaisical, oh, I'm okay, I'm eating okay, I'm not as fat as my cousin, you'll have a tendency to sometimes slip into poor health habits. And in the long run, you want your health habits as good as you can get them. Okay, some interesting things about sodium. Let's see. Oh, Kempner's work. Kempner really dramatically lowered his sodiums. Now, a lot of people will tell you sodium doesn't have that big of an effect on blood pressure. And when you go from about 10 grams a day down to about 3 grams a day, there's not that much effect. I mean, one study showed that it only bumped blood pressure down about 5 millimeters of mercury, but there's more than one study. There's other studies suggesting it does more than that, but even still, the point is made, not that big of a difference going from 10 grams to 3 grams a day. However, remember, we talked about the Yanomamo and a saltless population, and they're in the ballpark of 200 milligrams a day. When you reduce dietary sodium, Kempner noted this, from 3 grams a day down to about 200 to 500 milligrams a day, the patients could have a dramatic decrease in their blood pressure. And Kempner would have some of his really severely hypertensive patients on sodiums as low as 50 milligrams a day. And he had incredible results. He had patients with systolic hypertension as high as 50, One sec, I got to say something to my family here. Hey, can I try to keep a little quiet, please? Okay, sorry about that. All right. So that's a key point, because you'll hear some people say, oh, sodium doesn't make that big a difference. Well, it actually does if you get it down much lower. And, there's other points of view saying, well, you got to let people put salt on their food because it does make things taste a lot better. Me personally, I don't add any salt to my food. I'm pretty happy with it. I'm pretty simple. Oh, I got an interesting story about my brother. My brother was a great athlete in high school, state champion, freestyle Greco-Roman and wrestling. And then he went to college and, everybody just expected him to be an All-American, but he never was an All-American. And it was kind of a disappointment and a surprise. And he had exercise-induced asthma. So he just, college wrestlers are in really good physical shape. And so he would just get tired third period and he would tend to lose, in the big matches. So anyways, he kept on training and working out and he started doing this jiu-jitsu stuff, martial arts. And he then became a vegetarian in his 40s and his energy level increased so much. It was amazing. He became a 3-time world champion. So that can make a big difference. So exercise asthma, it could be dietary. So that's good to be aware of because some kids, like I said, like my brother, messed up his athletic career when he was young. Okay, let's see here. Oh, key thing too, when we talk about sodium and potassium, another reason why some people say, well, gee, you just put a patient on a plant-based diet, their blood pressure dramatically improves. That has nothing to do with sodium. Well, actually it kind of does because they're now, when they go to a plant-based diet, getting a lot more potassium in their diet. That then has a vasodilator and the ratio is flipped. Once they avoid the processed food, they're dramatically lowering their sodium intake because of that. So that can cause a big improvement in their blood pressure. And you really, at a minimum, want to be about 5-to-1 on the sodium. 5-to-1 more potassium, sodium. And by the way, I never count this or anything. We're going to look at a couple of nutrition labels and you're going to see there's a lot of foods, plant foods, they're like 100-to-1 more potassium. So if you're eating plant-based, you're going to get a lot of potassium. So that's a good thing. Okay, also, then other people say, well, maybe we should just reduce our dietary sodium for other reasons. I'm in agreement with that. And the reason I say that is sodium affects other things. Besides, it inhibits endothelial nitric oxide, which has some good benefit, even if your pressure is normal. Endothelial nitric helps prevent platelets from clotting, so your blood's a little bit less thrombotic. And there's also some evidence to suggest that it's important for some other enzyme systems. So what I'm saying is, I personally believe, sure, it can taste good. A little bit on your food is probably not a big deal if you get yourself in the ballpark, let's say, of around 2,000 milligrams. But I personally don't add it. And I think that you probably optimize your function, not add. There's one other school of thought. I'm not going to get into it right now. And I actually want to study this a little more myself. There's some people claiming out there, oh, well, they like a little sodium for their pre-workout meal. It rapidly expands their blood vessel volume, and they think that improves athletic performance. I'm not sure about that. I'm in the process of studying that. But I think for general health, I think it's probably wisest to not be adding salt to your food. That would be my intake from having studied it quite a bit, but I have to study it more from an athletic point of view. And I got a bunch of references here. By the way, at the end of the talk, I put references for all the stuff I'm talking about. I try to put them in an approximate order from when they were mentioned on the slides. I put a lot of key landmark papers and whatnot there. So if you're interested in that, they're there at the end. There's other little things that sodium does that I don't like, especially like salt, sodium chloride. The chloride's a negatively charged ion, so it's an anion, and the body has to maintain exact ratios of anions in your blood. So the more chloride you take in with salt, sodium chloride, the more you're going to displace the bicarbonate anions out of your blood, HCO3 minus. And you don't want to do that because that's a buffer. That buffers the blood pH. So your blood will tend to have a mild, low-grade metabolic acidosis from excessive intake of chloride with your salt. And that does other things. It also, that metabolic acidosis is buffered by taking some calcium, some from the muscle, some from the bones, and then that's excreted in the kidneys, increasing the risk of kidney stones, calciuria, and chronic calcium precipitation in the kidneys over time increases the risk of kidney failure. In addition, it'll tend to increase the amount of protons pumped in the extracellular matrix. And the guy who did a lot of research on that was Richard Moore, MD, PhD. So what I'm saying is it's contributing to an acidic extracellular matrix. You don't want that. Where does cancer grow best? In an acidic extracellular matrix. That's one of the little tricks that cancer does. Okay, so you don't want to be helping it by extra salt. You know that sodium increases the risk of stomach cancer, for example. So that's one of the problems with it, okay? So you got that double acidosis problem there. It's not good in your extracellular matrix. helping cancer a little bit. You don't want to help cancer. You want to prevent cancer. Okay, so this is just going back to the picture, just a reminder how we talked about how it works. Let's see, anything else interesting here on this slide? Well, just basically the key point that they're like a seesaw, the relationship between sodium and potassium, and you got to get that potassium. So that's almost like, let's say you go out to eat, and just to be socially polite, you had to eat something a little saltier than you wanted. Well, make sure you eat some fruits or some vegetables to get some more potassium to help counteract it. You get a lot of magnesium there too. It's right in the center of chlorophyll. All right, now here's just some typical nutrient labels on some foods, just to get a sense of how it works. This is a sweet potato, one of the best foods in the whole world. Look at the potassium, 337 milligrams compared to the sodium, basically about a 10-to-1 ratio. That's good. That's a typical, great food. Look how low the fat is, 0.6 grams, okay? There's almost like no such thing as too low a fat. So that's interesting. All right, here's blueberries, another great food. Potassium, 100 milligrams relative to sodium, 0 milligrams, okay? More than 100-to-1 ratio. Plenty of potassium there. Blueberries are a nice fruit. They're not so sweet. Of course, I like bananas, but bananas are real sweet. You got to put extra effort into cleaning your teeth afterwards. Blueberries, not such a big deal. Okay, here's just a generic cereal. I used to eat a lot of cereal growing up, and I could eat a cereal, big entire box in 5 seconds. But anyways, when I started looking at them more carefully, I went to the grocery store and I looked at every single cereal label, and I can tell you it was routine that they would have 200 to up as much as 350 milligrams of sodium per serving. That's a lot. And some of them would even have 0 potassium. So that's terrible. That's a very quick way you can look at a processed food and know that it's really not good for your health, is when you see the sodium is higher than the potassium. That's a highly processed item there. It's not a healthy thing. Okay, here's a little bit of some other food nutrition label things. And one of the reasons why I love potatoes and rice, look how low the fat is. Look how low the protein is. That's good. We've talked about this before, that, breast milk is only about 5 or 6% protein at a time of most rapid growth. You don't need more protein. You're not going to grow as fast the rest of your life. And the point being is, you don't want to create extra work for your kidneys. The protein's got the nitrogen, which fats and carbohydrates don't have, and you're just making extra work for your kidney. Plus, it's made out of amino acids, so it's acidic. That's additional work for your kidney to adjust the acid base. Fatty acids, you hear the word acid in there, but they're typically esterified to something in the body. It means bound to another molecule such that they're not having an acidic effect. So anyways, potatoes and rice are great foods to help you be healthy and help you optimize your body weight. Versus look at some of these foods. Like a lot of people think salmon's a health food. Look at it. You got 50% fat, 50% animal protein, tumor promoter, okay? 50% fat, that's a lot of fat. It's going to make your blood pressure worse, your diabetes worse. Okay, now here's a little bit about magnesium. Magnesium is a really good thing, and it's kind of hard to get an accurate measurement in the blood because most of it's intracellular. And here's what magnesium does. It's got a double positive charge, and it helps hold the phosphates together on an ATP. ATP right here, adenosine triphosphate, is the energy currency of the cell. It's like the $20 bill. And these phosphates really want to separate from each other because the powerful negative charges are repelling each other. But the positive charges of the magnesium hold them together. And that's why wherever you have ATP as a cofactor in a chemical reaction, you're also going to have magnesium. And that's why magnesium is essential for the KN-ATPase, maintaining the ion gradients across that plasma membrane. And as a matter of fact, if you don't have adequate magnesium, you cannot correct a low potassium. And so where do you get magnesium from? Here it is. It's right in the center of chlorophyll. Eat your plant foods, you'll get plenty of magnesium. It's literally right in the center of chlorophyll. Kind of like what iron is to hemoglobin in animals, magnesium is to chlorophyll in plants. All right, now this is going to get a little fancy. We're not going to go into all this. I just wanted to give you a taste of it, that we talked about how the calcium accumulation intracellular was causing your smooth muscle cells in your arteries to contract, thus narrowing the diameter of your vascular system, causing hypertension. And then I also make the point that it causes your neurotransmitters to be released in your brain cells, your neurons. And so that ends up being kind of a big deal. We're not going to get into it, but what I'm trying to say is sodium isn't just an isolated thing for blood pressure, and it's essential ion and has an essential balance with your potassium all throughout your body. And when your dietary intake is excessive, it's potentially impairing neuronal function. 65% of the energy, just like the voltage gradient in a neuron, is dedicated to that that K and ATPase. So you want it functioning optimally if you want to optimize your cognitive function. Okay. Like a lot of people had a previous problem. They might have had previous head injury from playing soccer or playing football or some other sport. And so they really want to optimize everything. So, if you're 20 years old, you got all this extra reserve, and a lot of 20-year-olds, they might eat junk food, stay out late and all this stuff. But what I'm trying to say is, if you want to go into your aging years, you're, let's say, after 50, 60, 70, and I've seen a lot of people look fantastic in their 70s and 80s. Look at Caldwell Esselstyn. He's 88 years old. He's still going around giving lectures, full of energy, really sharp. You could be like that, but you want to optimize all your health. You don't want to just go halfway on it. That'd be my recommendation. And this will be a little bit, we just started talking about it, but trust me, the same things that make your heart function well, they make your brain function better too. All right. Stress. What's the effect of stress? Well, stress makes the blood thicker. The classic thing is being chased by a tiger in the dark. That's how everybody learns what stress does. But there's some things that are not as well known. Imagine the tiger scratches you so you don't bleed out. Well, stress makes you more prone to clotting. It increases your blood thickness, viscosity, in the sense of being more prone to clot, because fibrinogen's elevated, factor VIII, clotting factor is elevated, von Willebrand factor is activated, and the platelets are activated to be more thrombotic. So it's making you more thrombotic. I'll leave it at that. So just know that, you don't want to stress a person out, especially somebody with a lot of atherosclerosis risk factors, because it does increase the risk of arterial thrombosis with myocardial infarction or stroke. It's not as important as a diet, but it's a contributor. Okay, theories of atherosclerosis. There's a lot of different theories. The most common one everybody's heard about is cholesterol theory. There's a lot of people talking about bacterial theory with regard to things like root canals and bacteria getting into the blood and being prothrombotic. And I'm just going to tell you, I don't think bacterial theory is that big a contributor. And the reason I say that is, let's say you have a atherosclerotic plaque, initially a thrombus, gradually an organized hematoma is what it essentially is. And you'll find some bacteria in there when you culture them out. It'll be a different variety of bacteria and whatnot. We do have some dormant bacteria in our blood. That's a whole other topic. But what I'm trying to say is Caldwell Esselstyn, Dean Ornish, and these others, they've been able to reverse coronary artery atherosclerosis. They didn't give any antibiotics. So what I'm saying is the bacteria that get into the thrombus, the atherosclerotic plaque, they're a secondary issue. They're not the primary issue. They're not the causative issue. I think they're like saprophytes. It's for them. It's a free dinner. Okay, a free meal. All right. You grow bacteria on a blood agricultural plate. Okay, that's good food for them. They need iron. The way our body prevents activation of infections is by having we sequester iron in the blood. And that prevents bacteria from growing. That's a whole other topic. It's an interesting one. But bacterial theory, no. Now, what about inflammation theory? Inflammation theory, that gets hyped a lot. Everybody talks about elevated CRP. But remember what I said. Go with the pathologist. When you talk about atherosclerosis, if I have to look at a paper by a pathologist compared to most other experts, in my experience, the pathologists tend to be right. CRP is an indicator potentially of inflammation, but it's a surrogate marker. When they look at the actual plaque itself under a microscope, there's not that much inflammation. There's, yes, some organization of a hematoma with resorption, but there's not that much inflammation. I look at these atherosclerotic plaques on CAT scans all the time, CT angiograms. They're about the same density as they're the same density as arterial thrombus. They're not the same as fat. They're not like an inflammation. When you have a inflammation, like an infection of an artery, an arteritis, it's usually circumferential. It's not eccentric on just one side. There'll be a lot of inflammation in the adjacent soft tissues, the adjacent fat, and it'll progress. It'll change over time. I look at these plaques. A lot of times they stay the same for years. Okay. An inflammatory process is going to change much more rapidly typically than that. Okay. For what that's worth. And then what am I getting at with atherothrombosis? Atherothrombosis was actually developed in the 1800s by Rokitansky, a pathologist, and then by additional pathologists. Did a lot of work on this in the earlier and mid 1900s. And the sort of the current pathologists are Dr. Sloop and Roberts most prominently. And that's what makes the most sense. Atherothrombosis is the all-encompassing theory of atherosclerosis that includes all the other things. Anything that makes the blood thicker or damages endothelial cell function is going to predispose to arterial clotting. Okay, it's about as simple as it gets. And trust me, I've done hundreds and hundreds of arteriograms. I did a fellowship in imaging guided surgery, also called interventional radiology. I've done hundreds and hundreds of arteriograms in the body and the brain, you name it. And I look at the CT angiograms and MRA angiograms all the time. And I can tell you atherothrombosis puts it all together. And once you look at it from that point of view and you include what I'd call hemoradiology, these things like blood sludge, rouleau formation, the thickness of the blood, all of a sudden, all kinds of things that before nobody could explain, they just make sense. Okay, so we talked about some of that. Is cholesterol really associated? Yeah. There's sort of a thing on the internet. A lot of people saying, oh, cholesterol doesn't matter. And there's a couple of reasons how I could explain why people could say that. Typically, normal cholesterol in this country is considered a total cholesterol of 200, but that's normed based on a high atherosclerosis, high-fat diet population. And the average American has a ballpark cholesterol, let's say around 220, 230, but that's really a high cholesterol. And why do I say that? Because that's a population with very high risk of atherosclerosis, where the most common cause of death is coronary artery disease, and stroke is up there as well. Versus you look at these epidemiology communities we looked at before that eat predominantly plant-based diets, they're going to have average total cholesterols, typically in the ballpark of about anywhere from 100 to 140. And they almost never have atherosclerosis. A good number to use for normal for total cholesterol is 150. And you will hear some things like the Framingham study claiming that they never seen a myocardial infarction in a patient with a total cholesterol below 150. And traditionally, that is true. You're also going to hear people who contradict that. They're going to say, oh, total cholesterol doesn't matter that much. I've seen patients have myocardial infarctions with lower cholesterols. And I'm going to say, yes, there's a new category of patients. A lot of older patients, they've been treated for a while with medications to lower their cholesterol, and they might still have myocardial infarction. Their health tends to be much more complicated, and they tend to be fragile. And so what I'm saying is the older a person gets, the more fragile they get. And that's why it's a good idea, the older one gets, to keep on improving all their health habits to maintain the same high levels of vitality and energy and health that you're capable of. But some of these older patients, they're complicated and they have a lot of other risk factors. As a person gets older, let's say over 50, they've got less endothelial precursor cells, less ability to repair an atherosclerotic plaque, a mural thrombus within an artery. So they're at increased risk. They're more salt sensitive, many of them, probably because they're not taking enough potassium. But there's other reasons why they become more prothrombotic. So just be aware of that. So cholesterol is less precise of a marker as a person gets older. As a matter of fact, I like this one painting called The Voyage of Life. And basically the young guy is all full of energy, and he doesn't even want to listen to anybody give him advice about health. He's so healthy and strong, he don't care. But the middle-aged guy's got all kinds of problems. That's a guy you can help the most. The older patient, you could help them if they really want to learn. A lot of times they're kind of fixed in their ways, and it's harder to get them to change anything. Okay, this was just mentioning some of these other papers. The Mr. Fit study. One sec, let me tell my family not to hold the dog. Hey, please control the dog. Hey, will you help me out with the dog?
Don't you guys feel like you're attending medical school? This is incredible.
Sorry about that.
No problem.
Okay, so Friedman and Roseman, they took a microscope 80 times looking at the eye, and they could just see the arteries occluding in real time after a high-fat meal. Mr. Fit study, they got 356,000 persons, and they had a linear graded correlation between blood cholesterol level and incidence of coronary events. It's about as good as it gets, and there's tons of data supporting that. So if you look into it, you'll see that it's obviously true. It's the case. Okay. What about some of the so-called good fats? There's a lot of research done on this, and Dr. McDougall's spoken about this before. You get, even if, like I said, the switch to the PUFAs, polyunsaturated fats, in the 1960s was not helpful. It didn't reduce coronary events. Blankenhorn's shown whatever type of lipid they eat, they'll have increased atherosclerosis risk. The point is to reduce total dietary fat. That's the key thing for reducing risk of coronary artery disease. And then, like I said, sodium is helpful as well. And of course, not smoking, not drinking alcohol, for example. We talked a little bit about the fragility of patients as they get older. Also, a lot of times they've lost the Windkessel effect in their ascending thoracic aorta from chronic hypertension, so they're more at risk for atherosclerosis. Also, people often become more sedentary as they get older, and exercise is really important. It helps your blood flow. It also gets your lymphatic flow to improve. And by clearing out those lymphatics, your immune system functions much better. And your immune system is your repair system for all kinds of things. It's not just to prevent infections. It also helps to keep your arteries free of atherosclerotic plaque. Okay, William Roberts, he's a cardiac pathologist. He wrote a great paper down here. It's called Quantitative Extent of Atherosclerosis in the Major Epicardial Coronary Arteries at Necroscopy, at Autopsy. a summary of 2,000 autopsies. It's his legacy paper of his career. He has a video on the internet, and I thought it was kind of funny. This is like the greatest paper ever written on coronary artery disease by this guy who devoted his life to it. And there was like 12 views. And I'm like, there'll be some TikTok thing, 3 billion views. And then here's this secret of keeping your coronaries open and no one knows about it. So anyways, the point was what he found at autopsy was patients who had coronary artery events, they had much, much, much more atherosclerosis in their coronary arteries than was clinically recognized, or even that was recognized on cardiac cath. Because the way you determine the extent of stenosis on a cardiac cath is you compare the narrowing to the adjacent arterial segment. So when you if you've got a baseline narrowing, then you can't get an accurate comparison. So the typical 50% stenosis at cardiac cath was really equivalent to a 75% stenosis at autopsy. So that's a pretty big difference. In addition, people were often categorized in the past based on a cardiac cath as having, for example, single vessel atherosclerosis. But when you looked at the same patient at autopsy, it was diffuse in all three of their coronaries. So whatever amount of atherosclerosis they have in one coronary, they tend to have in all three of the coronary arteries of the heart. So in addition, it's a relatively diffuse, it's almost like a systemic process. And that's a point I would make is whatever atherosclerosis you've got in the arteries of the heart, you're going to have something similar in the arteries of the legs, in the arteries of the Johnson, of the arteries of the brain. So it's really a wise move to try to just reduce your risk factors overall so you can avoid all these problems. Yeah, by the way, before this talk, I asked my family members, please keep the dogs quiet. It's not like I didn't anticipate this might happen, so sorry about that noise. So yeah, we talked about that, the pathologists having really good research. A couple quick points on the spine. Spine's not the most exciting topic in the world, but this is good to know. Here is the abdominal aorta. Here is the lumbar spine. This is L5, lumbar spine vertebral body number 5. This is lumbar spine vertebral body number 4, lumbar spine vertebral body number 3. And off the abdominal aorta posterior wall, you have the lumbar arteries. They pass at the mid-height of the vertebral body, and they give a small branch that goes to the top and the bottom of the vertebral body. The top and the bottom of the vertebral body are called the end plates, and their origin is from cartilage, bone components that arise from cartilage. It's like the growth plates in the long bones. They tend to have less blood flow. So the end plates, upper and lower end plates, are poorly vascularized to begin with. The disc of the spine has no arteries at all. It simply receives nutrients by diffusion from the end plate. So what I'm saying is the disc, even under good conditions, doesn't have that great of blood flow. And the body is designed with anticipation that there will never be atherosclerosis. So the point is, people very often will develop a lot of atherosclerosis on the posterior wall of their abdominal aorta, and that will get into the lumbar arteries and cause narrowing and eventually occlusion. And then they drop the blood supply to the spine. When they drop the blood supply to the spine, they then drop the nutrient supply to the disc. The disc is alive. The disc normally runs on anaerobic glycolysis. So it needs some glucose, and it also needs to expel its waste products. And that's also why it's good to walk a lot. It creates a natural milking action that gets the nutrients into the discs and gets the waste products out of the disc. So when a person develops a lot of atherosclerosis blocking up their lumbar artery and they don't exercise, their disc loses its blood supply. It becomes ischemic. And then what happens is the outer layer of the disc, which is kind of like a steel-belted radial tire, it's called the annulus fibrosus. It begins to crack, and then you start getting disc herniations. The soft material in the center of a disc, I think I got a picture of it. Here it is. The center is called the nucleus pulposus, and that material then will leak out of the center of the disc. And this can cause back pain because the disc is innervated. It has nerves that go to it, and they can sense pain. In addition, that disc material, if it bulges posteriorly, it can compress a nerve root. In the neck, it can compress the cervical spinal cord. And then what happens is when one level fails, like for example, here we've got the L5 vertebra, S1, sacral vertebra number 1. L is for lumbar. So at the L5, S1 disc, it's markedly flattened and narrowed. So that has lost all its nucleus pulposus material. It's a loss of height in a disc. And then it loses its ability to withstand weight bearing and movement. So what happens is the adjacent level will now have to bear more weight and take on more of the job of equally redistributing weight during body movements. So that will lead to accelerated degeneration of the adjacent disc, which also probably has a limited blood supply because atherosclerosis is everywhere in the body. And then this disc will progressively fail. Then the same accelerated degeneration happens at the next level. Oh, the orange stuff I drew in here was just to indicate a cartilaginous origin of the upper and lower end plates, which they're also called, the growth plates are called apophyses. So you hear these called apophyseal equivalents. And the bottom line is cartilaginous origin bone has less blood supply, and thus the disc is quite vulnerable. The little tear in the back is usually called an annular fissure. It means the same thing as an annular tear. And then what happens is when the discs fail, the body compensates. You know, the spine is very important. It protects your spinal cord, your central nervous system. So it's got a lot of proprioceptors. Proprioreceptor means to sense movement. So when it senses abnormal movement between two vertebral bodies, it will then try to stabilize that abnormal motion. And the abnormal motion is because of disc failure. So it'll grow these osteophytes that bridge to one another, and they fuse the vertebral bodies together. They're called DISH. DISH is just an acronym. It means diffuse idiopathic skeletal hyperostosis, DISH. And by the way, anybody reading any type of x-ray to spine sees this all day long, every day. And there have been some papers out, years ago about ischemia likely contributing to degenerative disc disease. I figured out, you know what? It contributes to the entire spine. It not only starts down here at L5S1, it goes all the way up the thoracic spine, all the way up the entire cervical spine, all the way to the skull base. And it'll even happen posterior. This is called the posterior longitudinal ligament right here. It'll occur right there, these bridging osteophytes, and that's called OPLL, ossification of the posterior longitudinal ligament. See, I got some additional pictures here. This is what I see every day. This is a typical American over 60 years of age. They got atherosclerosis all up and down their thoracic aorta and their lumbar aorta, stenosing off all these thoracic spinal arteries, lumbar spinal arteries, and their spine looks like crap. Their vertebral disc spaces are markedly narrowed. All their vertebral bodies are fused by DISH. And a lot of these older persons walking a little hunched over. They're kind of slow and hesitant. And this is OPLL, ossification of the posterior longitudinal ligament, where it typically begins along the posterior surface of the disc space. It's called posterior longitudinal ligament because that ligament that runs in this location is the posterior longitudinal ligament. And this is a bad spine. The person will often have back pain, and because they've got back pain, they won't want to exercise so much. Because they don't exercise so much, the muscles of the spine are atrophic. And these people are very at risk for severe fractures called chalk stick fractures. A chalk stick fracture is when they'll get a fracture through the spine from a relatively minor trauma, a fall. And I've seen these fractures. They can not only go through the vertebral body, they'll go through the posterior elements, the posterior spinal elements, posterior part of the vertebral body. And I've seen paraplegias from this. I see one of these every couple of months. They're called chalk stick fractures, bad fractures. But what I'm basically saying is this whole thing is due to lack of blood flow. And the reason I go into this is because this is, largely preventable. And everybody's aware of decreased blood flow to the arteries of the heart. That's a heart attack. Decreased blood flow to the brain. That's a stroke. But what I'm trying to say is, why would it be any difference with the spine? It's not. It happens all the way up and down. And again, the sooner a person gets their act together, the less likely they're going to progress to this extent. Because it ends up, the entire spine becomes all auto-fused. You have an auto-fused ischemic spine. Again, and I see this every day. And I actually wrote a book about this. I call it ischemic spine is most common most common cause of back pain. By the way, I ran a spinal injection clinic. I've written extensively on this subject, and this is so common. It's not even funny. And people will say, in the past, OPLL is a rare disease, seen more commonly in Asians. And that's all BS. I see it all day long, every single day. It is a degenerative disease related to the same process causing DISH. And it is super common. It is ubiquitous how common it is. Okay, we covered DISH, we covered chalk stick fractures. Oh, another thing that's not widely known. I see this too. Almost every day I see this. This is called epidural lipomatosis. This is the laying down of fat in the spinal canal, and that'll compress the neural elements within the dural sac where all the nerve roots travel together in the cerebral spinal fluid. And so a lot of people, they're fixated. Oh, my back hurts, I need spine surgery. If only I could get spine surgery. If only I could get spine surgery. And it's like, what's going through my mind is what they really need to do is lose some weight. And then they'll decrease this epidural lipomatosis and they'll have more room for the nerves in their spine. Okay, vision disease. Another point I would make is a lot of these diseases of the eye, they're really kind of all highly related. There's subtle differences between them. I made a mnemonic in an acronym: CDOG: cataract, diabetic retinopathy, age-related macular degeneration, hypertensive retinopathy, glaucoma. And there's some subtle differences between them, but they're all pretty similar. When you reduce your atherosclerosis risk factors, you will decrease your likelihood of having a symptomatic any one of these things. There was also an interesting thing was Dr. Kempner showed lots of patients who reversed hypertensive retinopathy and diabetic retinopathy. And before he did that, it wasn't even known that that was possible. Okay, so here's the blood vessels when they come out of the optic disc in the back of the eye. Here's the fovea, and the macula is the area right around the highest visual acuity is coming out of the fovea with all the cones for color vision, and normally no blood vessel growing over them because that way they can get better blood flow. With diabetics and hypertensive, they'll get little bleeds into the area of the retina, the posterior part of the eye. The hypoxia will activate this hypoxia inducible factor to cause vascular endothelial growth factor to cause more blood vessels growing in the back of the eye. And the point I'm making is the eye is actually part of the brain. The retina is thought to be part of the brain. The optic nerve, cranial nerve too, is part of the brain. So it's a pretty safe bet. Whatever's happening in the eye, something similar is happening in the brain, and you don't want that. And I made the observation, I see these microbleeds around the outer surface of the brain, and I'm like, gosh, these little microhemorrhages, they call them cerebral amyloid angiopathy, but they look just like a hypertensive microbleed, cerebral microbleed. And why wouldn't they have the same thing in the eyes? It turns out, I studied it, they do. So that's kind of interesting. And the good news is you reduce your cardiovascular atherosclerosis risk factors and you decrease your likelihood of ever having vision loss, and you don't want to need a cataract surgery. Cerebral amyloid angiopathy tends to cause peripheral microbleeds. Hypertension tends to cause central microbleeds in the brain. But the truth is, lots of times I can't tell. Nobody can tell. I look at brain MRIs all the time. I've seen tons of cerebral bleeds. And if they're all central, I can say, sure, that looks like hypertension. If they're all peripheral, I can say, sure, that's amyloid angiopathy, which is associated with Alzheimer's. But the reality is, very often they're all over the place, and we don't know what they come from. And we just attribute them. I think they're due to hypertension primarily. What are some other interesting things? Glaucoma. Well, it's strongly associated with high blood pressure. Well, blood pressure control and less glaucoma. Okay. And some of these same things, hypoxia of the macula, age-related macular degeneration, are some of the same things that are associated with cancer. Okay. So you decrease your risk of macular degeneration, atherosclerosis, you're also decreasing your risk of cancer. What about cataracts? Cataracts are pretty complicated. There can be glycation of the proteins in the lens, so you avoid things that tend to glycate proteins. You can get them from exposure to other things, like used to be the contact lenses were stored in a thimerosal mercury preservative. That increases the risk of getting a cataract. If there's been trauma to the eye, previous surgery, radiation. So also watch out for galactose. Just because a person could drink milk and split the lactose into glucose and galactose, that does not mean they've got the enzymes to handle galactose well. It's thought that the galactose can be toxic to the eyes and worsen cataracts. In addition, I think a galactose is potentially toxic to any round thing. It can be toxic to the testicles. It can be toxic to the ovaries. It increases the risk of ovarian cancer. So that's other good reasons to minimize your intake of dairy. Let's see here. Okay, now we're going to start getting into the diabetes stuff. And I think this is pretty cool stuff. I don't even got a clock. Am I doing okay for time?
You have about 30 minutes left and you're doing great.
Oh, thank you. Thank you. I think it's going to work out okay with the time here. Okay, we're going to see additional pictures of this, this drawing here. This is the mitochondria, the energy factory of the cell. And it has a double membrane. The outer membrane is called the outer mitochondrial membrane. It's abbreviated here OMM. And the inner mitochondrial membrane is often abbreviated IMM. And the inner mitochondrial membrane is where lots of things are happening. When glucose is metabolized, it first goes to the cytoplasm and it goes through glycolysis. It then goes to the center of the mitochondrion. That's called the mitochondrial matrix. And then it produces, in the process in the mitochondrial matrix is called Krebs cycle. And that produces electron carriers called NADH and FADH2. Okay. And those then go to these proton pumps in the inner mitochondrial membrane. And I realize this is kind of technical, but you know what? Once you get the concepts here, it's all going to make sense. And I can tell you, this is the great secret of understanding diabetes here. And by the way, if you want to see a research paper, the research paper the best one on this subject would be Unifying Theory of Diabetic Complications, written by Michael Brownlee. It won an award as the Banting Award in 2004. It was published, though, in a diabetes journal in 2005, but you can find it. If you look up Michael Brownlee, Unifying Theory of Diabetes Complications, you will find this paper. And if you go to the diabetes.org site, you can even watch the video of him giving a lecture. I've read tons of papers on diabetes. I think this is the most incredible paper ever written on diabetes. I think Brownlee is a genius. It's incredible stuff here, and it's all going to make sense. It's not as complicated as this drawing would imply. Okay, so the electron carriers go to these proton pumps, and the reason for proton pumps is the way the mitochondria works is it pumps protons, so that's just a positively charged hydrogen, into this space between the two membranes. So that's called the intramembranous space. And again, it builds up a gradient. The human body loves to build up gradients and then to harvest that gradient to make something. So all these complexes, numbers 1, 3, and 4, are proton pumps, and they keep on pumping more and more protons into the matrix. Their energy comes from handing off these electrons. The electrons essentially roll downhill, meaning that they move towards proteins that have a stronger and stronger desire to grab those electrons. And the ultimate electron acceptor is oxygen. Oxygen has a very high electronegativity. Electronegativity means the desire of an element to grab electrons and hang on to them very tightly. And so basically from complex 1 to complex 2, complex 3, complex 4, these electrons are rolling downhill towards oxygen, which is the strongest grabber, ultimate acceptor of the electrons. And at that point where it grabs an electron, oxygen is going to be converted into water, into H2O. So this is the way it normally works. The electron carriers from Krebs cycle, they go to the proton pumps, drop off their electrons. Proton pumps use that to pump a proton into the intramembranous space, build up a gradient. The electron is just passed on down the line, like an assembly line, to the next proton pump that has a little bit stronger desire to grab that electron, and it goes all the way down to complex number 4. Then what happens is we've built up this proton gradient, and now it's time to harvest it. So this membrane protein here is called ATP synthase, and it will now allow a hydrogen to come back into the mitochondrial matrix, and that provides tremendous energy. Think of these things too like a mill wheel. They'll spin this pump, and that enables a phosphate to be added onto ADP, adenosine diphosphate. And that's how ATPs are made. So because oxygen is used, this is what aerobic metabolism is. It means to make ATP using the mitochondria. And that is in comparison to anaerobic metabolism. Anaerobic metabolism means to generate energy from glucose within the cytoplasm, and that only yields 2 ATP per glucose. When you generate energy in the mitochondria, you will generate 36 ATP per individual original glucose molecule. So that's 18-fold increase in energy, a tremendous increase in the amount of energy gained from the food stuff. Okay, so all that extra energy is what enables humans to exist. That's what enables multicellular organisms to exist, because an individual cell has to do a lot of work. Imagine that you're a liver cell. You got a lot of jobs to do. You got to detoxify toxins. You got to make bile. You got to maintain blood glucose during fasting. There's a lot of work to be done. So that takes energy. All right. So aerobic metabolism is how normal cells make their energy. And now we're going to talk about a little bit of a problem. Okay. When a person eats excessive amounts of dietary fat, it's been shown that that causes insulin resistance. And this researcher, Brownlee, figured out how it happens. What ends up happening is he didn't know the exact mechanism of why it happens. He just figured out what happens. And what he figured out was too much fat gets into the mitochondrial matrix, and it causes too many electron carriers to go up to these pumps. When too many electron carriers too rapidly go up to these proton pumps, then too many protons are pumped too quickly into the intramembranous space. And what that does is pump number 3, complex number 3, gets overwhelmed, and it can't pump against this high pressure. And when it can't pump out the protein, it's not able to hand off its electron to the next step in the electron transport chain. So the electron goes backwards. The electron will bounce off coenzyme Q and go down to oxygen. And now oxygen is only accepting a single electron. That's not what's supposed to happen. And when oxygen gets a single electron, it's sitting in its outer molecular orbital. There's like satellite orbitals for the electrons around the nucleus of an individual molecule for the oxygen. And they normally have the electrons paired with each other. When you have an unpaired electron, that oxygen will become hyperreactive. It becomes what is called a free radical. It also is described as an ROS. ROS means reactive oxygen species, and these can be very damaging. Now, it's normal to make a couple of these when you're running electron transport. So small amounts are normal, and the body's very good at handling that. SOD stands for superoxide dismutase, and that will neutralize the superoxide anion by converting it to water and oxygen. So the body is perfectly capable of handling the normal small amounts that occur. But when there's an excessive amount of fat getting into the mitochondrial matrix too rapidly, then you start generating excessive amounts of superoxide, and superoxide causes all kinds of problems. It creates a cascade of reactions that will damage DNA. It'll also create additional reactions that can damage these mitochondrial membranes. By the way, this is something to be aware of. We're going to come back to it. See the CL here? That stands for cardiolipin. And notice how cardiolipin is different than all these mitochondrial membrane phospholipids. It has 4 fatty acid tails on it. And the CL for cardiolipin, I colored in the center of the phospholipid head here. It's also bound to cytochrome C. That's going to be very important. Cardiolipin has a unique structure and a unique relationship to cytochrome C to keep the mitochondrial membrane functioning properly and to keep cytochrome C located where it belongs in the intermitochondrial membrane. And cardiolipin, like I said, it has a very special structure. We're going to come back to that in just a moment. And that's going to be one of the fascinating things about diabetes. And I actually think it's one of the great secrets of understanding cancer and aging. Okay, so the superoxide causes injury to the DNA within the nucleus of the cell, in addition to the mitochondrial DNA, and that will activate a DNA repair enzyme. The DNA repair enzyme is called PARP, and that's a polyadenylyl ribosylating protein. I also throw an R in there for repair, and that's going to try to repair the DNA. But there's an enzyme from glycolysis that shuttles back and forth to the cell nucleus called glyceraldehyde 3-phosphate dehydrogenase. I realize this sounds kind of complicated. It's just a story with a sequence of steps. And the key point is just to get an overall sense of what's happening. So what's basically happening is everything is going backwards because too much fat got into the mitochondrial matrix. And when everything goes backwards in electron transport, which is like the third step of metabolism. So the 3 steps of metabolism are: number 1, glycolysis; number 2, glycolysis in the cytoplasm; number 2, Krebs cycle in the mitochondrial matrix; and then number 3, electron transport on the intermitochondrial membrane. Those are the 3 standard steps for making energy from glucose. And the point here is that when excessive dietary fat overwhelms the intermitochondrial membrane with too many electron carriers, it goes backwards. And that means Krebs cycle it's like a traffic jam with all the routes blocked on the highway. Krebs cycle has to back up. Glycolysis has to back up. And it's even worse than that. Specifically, this important enzyme, glyceraldehyde 3-phosphate dehydrogenase, is going to be inhibited, and there's going to be major consequences for all of metabolism because of that. Okay. And then we know that fat causes insulin resistance. Dr. McDougall went through all the details of this, and this has been summarized elsewhere. So just know that fat causes it. We don't need to go back through all these studies. There's tons of them that show that. All right. One thing too is we're going to get back into that mitochondrial physiology. I'll just tell you, this is a staging system for diabetes that I kind of made up based on reading a lot about it, because I think it makes it simpler to understand. Fat is causing a lot of problems with your body's physiology. First of all, it accumulates in the skeletal muscle. That's the earliest detectable finding of insulin resistance. And that's been shown through numerous methods, most definitively by Gerald Shulman with nuclear magnetic resonance spectroscopy. The second thing to happen is once you've accumulated fat in the skeletal muscles, you'll accumulate it in the liver, and then you'll accumulate it in the pancreas. Accumulation of fat in the pancreas is damaging to the beta cells. Those are the ones that make insulin. Then once the pancreas beta cells fail, you can't make insulin anymore. And then a type 2 diabetic is almost like a type 1 diabetic. They can't make insulin. And so then they start to develop all these secondary complications of insulin-dependent diabetes. And we'll talk about these. It causes problems in the eyes, arteries of the feet, the kidneys, the brain, the heart. They most often die from a myocardial infarction, but it's a big disaster. So what I'm basically saying here is insulin resistance is a major big deal. It doesn't just mean blood sugar is a little high. It's a disaster of metabolism. Okay, so now here's a drawing showing the sequence of these clinical stages of diabetes. And again, like I said, you won't find this in the book. This is something I kind of, put together from reading a lot about it. Fat accumulating first in the skeletal muscle, and that's the beginning of skeletal muscle insulin resistance. Normally after you eat, eating a meal is called prandial. So postprandial means after eating. About 80% of your glucose is going to be stored in your skeletal muscles. They're like the biggest organ system in the body. Anything extra, they just store it as glycogen. That's a good place for it to go. When the glucose can't get into the cell because the fat overwhelms the cell. In a sense, the fat has too many calories inside of it. In a sense, it's been called overnutrition. The skeletal muscle cell will shut down the glucose type 4 transporters to come into the cell. And this is actually one of the key things. Out of this entire talk, what I'm about to share with you is I think one of the most important points here. The skeletal muscle cannot control how much fat comes in. The literature suggests that what's happening is it's taking up lipid in a concentration dependent fashion, meaning that the more blood lipid there is, the more lipid's going to go into that skeletal muscle. And when that amount is excessively high on a prolonged chronic basis, what's going to happen is the skeletal muscle is going to accumulate fat and it's going to overwhelm electron transport like we just saw in that previous slide. And when the skeletal muscle is not able to take up the glucose after eating postprandial, now that glucose is floating around in the blood, it has to go somewhere. And normally it would have been, like we said, burned by the things that use it, like the brain, and stored by the skeletal muscle. Now it's high everywhere. And there's a lot of tissues that can't control their uptake of glucose. Well, first of all, the liver gets an excessive amount of glucose and it'll start converting it into fat. Now you get a fatty liver. When you have fatty liver, now the liver itself becomes insulin resistant and it can no longer regulate blood glucose level. So it'll keep on excreting glucose into the blood, running gluconeogenesis, for example, even when a person has a normal blood glucose. So this will cause fasting hyperglycemia. The skeletal muscle inability to take up glucose is going to cause postprandial hyperglycemia. So we have a progressive worsening of the person's diabetic condition as they go from fatty muscles to fatty liver. And now we'll start accumulating fat within the pancreas. It'll accumulate in the beta cells and it'll cause the beta cells to fail. And when the beta cells fail, we'll see this on CAT scan all the time, a fatty atrophy of the pancreas. That's type 2 diabetes. And when the pancreas cells fail, the beta cells, they can't make insulin. Now the person starts having, continuous hyperglycemia, and the hyperglycemia damages especially the tissues like the retina of the eye, the kidneys, the mesangial cells in particular, and the endothelial cells lining the artery, because those cells cannot control their rate of glucose uptake. They take up blood glucose in proportion to the blood glucose level, because normally in a person eating a healthy diet, the blood glucose is carefully regulated. It's not an issue. And the same thing that we just talked about happening from excessive dietary fat getting into the mitochondrial matrix now happens in these cells because they get excessive amounts of glucose coming into their metabolic cycles of glycolysis and Krebs cycle. So that's my key point. It all begins with excessive amounts of dietary fat. All right, now here's something that I think is really cool. Why does it all happen? Why is it such a mess? And I think what it really comes down to is we're not designed to routinely eat large amounts of fat. I think we can handle a big fat meal here and there. The body has some reserve to handle that. But when a person, like a typical American, eating high fat meal 3 times a day, that just totally overwhelms your cell's ability to keep out the fat. And there's a couple ways that fat gets into a cell. It's thought to come in through something called a CD36 protein, transmembrane fatty acid transporter protein, but it's also been shown that it appears that it's doing what's called a flip-flop maneuver, whereby a typical fatty acid in the blood is going to be deprotonated. It can interact with the phospholipid head. It can become protonated, thus being neutral in its charge. And then intercalate itself into the outer layer of the phospholipid bilayer, and subsequently it flips into the inner bilayer, and then it moves into the cell cytoplasm. And there's a big paper. This is a pretty profound paper by Anthony J. James Hamilton, 2020. Inhibitors of fatty acid transport across plasma membranes by CD36 to disrupt intercellular metabolism do not affect fatty acid translocation. So what is that saying? They tried a bunch of different ways to inhibit CD36 to see if that was the rate limiting step for fatty acid transport into the cell. And what they found was they weren't able to, their ability to block CD36 really didn't make much difference. The fat was getting into the cells. So what's the point? It appears that the skeletal muscle cannot stop fat from getting in. And so it appears that in a concentration gradient dependent fashion, fat is getting into the skeletal muscle cell. There is only one way to prevent that, and that is to reduce dietary intake of fat. There's no other way that I'm aware of. And that's a big deal because diabetes is a disaster for metabolism. It's a disastrous way to age. It causes tons of problems. Most of the diabetics I speak to, they're cognitively impaired. It's very sad. They're going blind. They're in kidney failure. Every day I see multiple diabetics getting their feet amputated, their legs amputated because they got no blood flow. It's a disaster. And what I'm telling you, this is what you need to know. This is what sets you free from diabetes. Reduce dietary intake of fat. There's other mild contributors to it. Excessive psychological stress is going to raise cortisol and catecholamines, increase blood glucose a bit. You're going to have sodium excessive dietary sodium has a mild effect. But the big one affecting insulin resistance and causing is excessive dietary fat intake. So this is a profound thing. I got another reference too about this, and it's big stuff. Okay. Fatty liver, we talked about that. That's just the liver becoming insulin resistant. And basically it means you got pre-diabetes and you're heading towards diabetes. Lots of people got fatty liver. Fatty liver is so common on a routine ultrasound or a CAT scan for other reasons, looking for kidney stones or something. It's routine to see fatty liver. It's super common. It tends to be more intense and worse in alcoholics, but it's super common. It's so common. If an ultrasound requisition says elevated LFTs, you almost don't even need to look at the films. I can tell you that patient has fatty liver. All day long, I see that. So rising LFTs, liver function tests, like AST enzyme in particular, that's a good, and ALT. Those are elevated liver function enzymes. Trust me, that usually means fatty liver. There's other things it can mean, of course, but fatty liver is by far the most common thing. Here's another point, not widely known. When a person has insulin resistance, they're constantly releasing fat from the fat cells because you'll get insulin resistance within the fat cells themselves. So they won't be able to shut off lipolysis, which means the breakdown of fats. So they're constantly pushing fats into the blood, and these can contribute to insulin resistance and diabetes. Okay, so unifying theory of diabetes complications. We talked about the work of Michael Brownlee and his group. Fantastic. Let's see what else is interesting in here. Oh, now we're going to get a little bit more into some of the complications. So we were talking about glycolysis. Glycolysis is the set of reactions for the initial breakdown of glucose to be converted into energy. Glucose, by the way, used to be called glycose, and that's why glycolysis, the cycle, is called glycolysis. I'm also going to tell you a little trick here. It's going to sound like no big deal, but if you're interested in understanding this metabolism, it's useful to know. When you make a Fisher projection is like a fishing rod. It's a straight line in comparison with a Haworth projection, like a cyclic ring. So a Fisher projection, you're going to have the elongated open form of glucose, and it's an aldehyde. So I remember it. I just made this up, but trust me, it helps. Glucose. Okay, it's an aldehyde. Just know that it's an aldehyde. The next reaction, hexokinase. Just know the first reaction is by hexokinase. Comes glucose 6-phosphate. You put a phosphate on it, you trap it in the cell by putting a big charge on it. Now the glucose can't pass out of the cell. Then we go on through these next couple of steps till we get to glyceraldehyde 3-phosphate. And that's the one that's converted by glyceraldehyde 3-phosphate dehydrogenase into the next reaction intermediate in glycolysis. And the reason I drew this in blue letters is this is the one that gets inhibited by PARP, which is the consequence of the backup of electron transport and the free radicals within the mitochondria. And this ends up being a big deal because when this is blocked, this accumulates, glyceraldehyde 3-phosphate, and all kinds of bad metabolic reactions happen from that. And remember that glucose is an aldehyde, and so is glyceraldehyde. Okay, so like we said, this whole sequence of reactions is leading towards that enzyme, the one that was in blue on the previous slide, being inhibited. All right, so now here's this thing that we talked about, the blue enzyme, glyceraldehyde 3-phosphate dehydrogenase being inhibited. And what that means is the substrate before it accumulates. And when it accumulates, it activates a lot of bad pathways. It's going to activate the PKC pathway, that's protein kinase C, and that's going to cause lots of problems. It gets converted into diacylglycerol, DAGs, and that sort of is the main thing activating protein kinase C. But man, that's a bad pathway. That's like destroys person's cellular function. The next thing is glyceraldehyde gets made into something called methylglyoxal, MgO, and that gets made into all the AGEs. The AGEs are advanced glycation end products. And I know we're kind of going into some complex stuff, but the general key point to get from all this is high-fat diet through numerous pathways destroys cellular function. So diabetics have terrible aging and they suffer a lot. Like some people say, oh, I want to enjoy life eating all this high-fat junk food. There's nothing enjoyable about going blind and being in kidney failure and dying prematurely. Okay. Okay, so now here we look at glucose. I just want to show that there's an enzyme system in the body called aldose reductase. And aldose reductase normally detoxifies toxic aldehydes, which are the byproducts of reactive oxygen species causing lipid peroxidation. And that's a fancy word, but the bottom line is we have good repair systems and defense systems in our cells to keep us healthy. Aldose reductase is one of them. And it's also, when it gets activated, because there's excessive amounts of intracellular glucose, it'll convert it into sorbitol. And what ends up happening is it uses up the antioxidants. So when you have bad metabolic things happening, your body has repair systems, but they're limited in their amount. So this sequence of reactions leading to using up your glutathione antioxidant to handle the toxic overflow from excessive dietary fat is then going to make you less able to protect yourself from infections, from cancer, from atherosclerosis. Okay, so this is a fancy page, but the reason I'm showing you this, a lot of you, I'm sure, have heard of advanced glycation end products, AGEs. AGEs cause accelerated aging. And what I'm trying to say is the main spot they'll come from is from this process of high dietary fat leading up to a backup of metabolism and accumulation of this glycolysis intermediate, glyceraldehyde 3-phosphate. It goes to MgO, methylglyoxal. Then methylglyoxal is a disaster. It goes outside the cell and starts cross-linking proteins in the extracellular matrix, the collagen around the cells. This will destroy the basement membrane in the kidney, leading to kidney failure with diabetics, glomerulosclerosis, for example. It also impairs endothelial function. This is an endothelial cell, by the way, damaged by diabetes. It will go out into the blood and glycate blood proteins like albumin. And then, by the way, some glucose, when you're hyperglycemic, can glycate. Glycation is a sugar binding to a protein, basically, for our purposes. That's what it means. It can mean a little more than that, but for our purposes, that's adequate. So the albumin that's glycated, or the hemoglobin A1C that's glycated, now we'll call them an AG, advanced glycation end product. Cells like the macrophages, the immune system cells, will have receptors for them. They're called RAGE receptors, R for receptor, AGE for advanced glycation end product. And this will then activate something called nuclear factor kappa B. And what that means is it's going to activate the immune system to create inflammatory reactions that damage tissue and that also make the platelets more thrombotic. So this is partly why diabetics have so many strokes. And they have so many heart attacks, and they also clot off the arteries in their feet and their legs, and they end up with amputations, is because they initiate multiple metabolic pathways that increase the tendency of the blood to clot. They also activate the plasma membrane NADPH oxidase, typically called NOx, and that starts producing superoxide reactive oxygens, initiating cascades of oxidative stress. So you can see here, you get multiple vicious cycles going in a bad direction due to excessive dietary fat. It's a big deal. So anyways, that was the purpose of this whole thing. And that's the way to think of this, physiology and biochemistry. Just think of it as a story. And it all starts from blocking glycolysis due to excessive dietary fat in the mitochondrial matrix, leading to all these sequence of steps. Okay, and then getting back to it, why is it so bad? Because one of the things I talked about is your chance to repair things would be your glutathione. Normally, the cell's got a repair system. A little bit of MgO, you can repair it. but we just trashed all our glutathione, wasting it on the diabetic hyperglycemia. And this is why diabetics are so vulnerable to infections, because their immune system, their antioxidant system, it's all been used up dealing with things like this excessive dietary lipid and the secondary hyperglycemia. Okay, so now we had initially mentioned the protein kinase C pathway, and this is a disaster. Protein kinase C, once it gets going, first of all, it blocks the glucose type 4 transporters from going up to the plasma cell membrane in the skeletal muscle, for example, causing insulin resistance. Then it activates multiple harmful metabolic pathways. It blocks nitric oxide synthesis, so the artery vasoconstricts and the platelets become more aggregating, more prothrombotic. It increases the bad thing coming out of endothelial cells, endothelin, increasing tendency to clot. Other things that'll increase the tendency to clot. It starts increasing vascular endothelial growth factor to produce new blood vessels that grow over the fovea, the optimal spot of visual resolution, so people go blind. Then it causes inflammation, oxidative stress. So bottom line, it's a disaster. Metabolically, it's all bad. And I say this too because I've talked to a lot of diabetics. They're like, oh, I'm doing okay. My diabetes is under control. No, it's not. If you've got insulin resistance, you've got a problem. I don't care if your blood sugar is normal. It's a big deal. And so this was sort of the key point. The skeletal muscle is not able to control the amount of fat that comes inside those cells. And therefore, the only thing you can do is reduce your total dietary fat intake. And so, we're made to ingest a small amount of fat. There's some normally present in plant foods, and that's all good. But when people start eating these artificial foods, these oils, or they're eating meat, they're cranking up their dietary lipids very high, and the body is not made for that. Okay, this I already showed the flip-flop maneuver. I thought that was really interesting, the way the skeletal muscle can't control it. And here's cardiolipin again. We're going to go briefly a little bit more. We're almost done here, but just something on cardiolipin because it's a cool little phospholipid. It's like a double phospholipid. So here's cardiolipin's structure. Instead of just having a typical phospholipid would be like half of this thing, where you've got a glycerol, 3-carbon molecule with a phosphate. That's why it's called phospholipid. That's the polar charge component of a lipid bilayer, the plasma membranes of a cell. Then you got the 2 fatty acid tails coming off of it. The unique thing about cardiolipin, it's like 2 phospholipids stuck together with a glycerol in the middle. So it's a giant phospholipid, twice as big as a normal phospholipid. And this is sitting in the intermitochondrial membrane, and it is bound to cytochrome C. Okay, notice all these double bonds. The typical tails in these things are going to be like linolenic acids, okay, or linoleic acid, actually is what I should have said. I should have drawn 2 double bonds. I was in a hurry. I drew 3. But again, it's a PUFA. Typically, the fatty acid in this location is a PUFA. What does that mean when you got a PUFA, polyunsaturated fatty acid? It means it's highly vulnerable to lipid peroxidation. Where are reactive oxygens being generated? They're being generated in the mitochondrial matrix due to excessive dietary fat, and they can initiate a chain reaction of lipid peroxidation and destroy these fatty acid tails. And subsequently, when you destroy your cardiolipin, it'll lose its binding relationship to cytochrome C. When cytochrome C is released from cardiolipin, it will exit the intermitochondrial membrane, and it actually can then pass through the outer membrane, and it tells the cell to go into apoptosis. So what I'm saying is excessive dietary fat puts the individual cells at risk for apoptosis. That's programmed cell death. I mean, that's as bad as it gets for a cell, okay? And, what causes things that'll cause mitochondrial dysfunction and increase reactive oxygens? Excessive intracellular lipid. Excessive intracellular glucose is a secondary complication of insulin resistance. That's where that comes into play. Tissue hypoxia. Well, what causes tissue hypoxia? The main thing that causes tissue hypoxia, we spoke about it earlier in the research of Kuo, Meyer, and Friedman, is excessive dietary fat causing rouleau formation and blood sludge effects. Okay, those also increase your incidence, your risk of cancer. Look at the Warburg effect. Warburg was a biochemist who won a Nobel Prize in 1931, and he showed that if you make cells in tissue culture, any type of cell, hypoxic, 35% or more, some papers say 60%, others say 35% or more, you will increase the likelihood. A lot of those cells will die from the ischemia, lack of oxygen, but some of them will go into dedifferentiation, and they'll turn into cancer. So what am I basically saying is excessive dietary fat is a major, major risk factor for initiating cancer. Of course, I know the work of T. Colin Campbell, the animal protein is a bigger promoter, but promotion of cancer cell, making it grow, is different than initiating cancer. All right. And excessive dietary lipid does that. And so then you can also get all those negative cycles going, positive feedbacks of negative cycles, vicious cycles, if you will, going. So you want to stop that. You want to, nip that in the bud, so to speak. And the way you do that is decrease your dietary fat intake. That's sort of the rationale for the whole thing. And I believe it's good to have, an understanding of things, because then you're motivated and it's easier to make wise decisions about your health and your nutrition. This was just a quick summary of, an example of lipid peroxidation, what happens. So we talked about that methylene bridge being between the two double bonds and then having a weak grip on that hydrogen. So that hydrogen gets plucked off, and then you got a free radical where you got this unpaired electron sitting on that methylene bridge carbon. Oxygen will react with that, form a peroxide. A peroxide just means two oxygens in a row bound to each other. And this will then initiate a series of chain reactions, destroying the lipids in the plasma membranes and in the mitochondrial membranes. And that'll destroy the mitochondria. The cell can't live without the mitochondrial energy production other than a cancer cell, which is a special circumstance. And you've got some repairability initially with your superoxide dismutase and your other antioxidants. But when they're overwhelmed, that's it. That cell dies. Okay. And it's not good. Eventually, the patient gets sicker and sicker. Okay. So this was just, again, a reminder. Here's the cardiolipin and the intermitochondrial membrane bound to cytochrome C. So when you get these excessive reactive oxygens, a chain reaction of peroxyls, actually, it's a hydroperoxyl, will get into the membrane of the intermitochondrial membrane. It'll destroy the fatty acid tails of cardiolipin. When it changes shape, it releases cytochrome C. That then exits and triggers the caspase series of reactions to initiate apoptosis, programmed cell death. So it's not good. Okay, so we talked about, optimizing your fat, your diet, your health habits, your exercise, your sleep, get some sunshine, all that. I'll just show a couple things about exercise. We're almost done here. I only got about 2 or 3 slides. I like to, when I come home, I like to read a book and I'll walk. It's good to walk. Why not walk while you read? Ride an exercise cycle, read a book. Okay. Also, I like to walk when I'm eating. If someone's around, maybe I'll talk to them, sure. But if no one's around, I'll walk while I eat. Or sometimes I watch internet videos, which is, I enjoy doing that. I learn a lot from that, but I don't get as much exercise. Anyways, walking is good because it does essentially kind of like what insulin does. It gets the glucose type 4 transporters up to the skeletal muscle to get that glucose into the skeletal muscle. So it lowers insulin resistance. I used to have this in my old house in the backyard for playing basketball. There was like a tennis wall to hit tennis balls and then play some basketball. And I put a big net in the back of it, which I loved it. You could hit tennis balls. That way they don't, go out in the other yard. And that was all great. But I pushed my luck a little bit with the wife. My kid wanted me to help him with basketball. I was working a lot at the time and he needed more practice time. So my wife wasn't home one day. I put a basketball court in my living room, and I can't understand why she wasn't thrilled with that. We put these wooden boards up to block the length, but I'm telling you want a great way to exercise, put a basketball court in your living room. But man, my wife made us move because of that. So, but anyways, I loved it while I was there. The kids liked it too. Everybody liked it, but she didn't like it. But anyways, that's a indoor basketball court, surprisingly good way to exercise. And that's basically all the slides I got. I got this reference here. So if anybody wants them, here's the first reference page, second page of references, third page of references, and fourth page of references, fifth page of references. Wow, I got a lot of them. That's it. So hopefully that was helpful.
Yeah. Are you like a professor at a medical school?
Oh, I would love to be, but it's a long story what happened. I always thought I was going to be an academic research professor, but I was at Harvard for my fellowship, and I already written some books by that point. I've written 2 books by that point. But what happened was, my mom got sick with cancer. I was closer with my mom than anybody in the whole world. So I came in to help take care of her, got my girlfriend pregnant, then kind of had to stay where I was at. And it's a long story, but that's how I kind of drifted out of academics. But I do some teaching, which I like. I should do more teaching. I wish I could. And I would like to someday do more teaching, but, that's sort of, and I wrote a couple of books that gets me interested. I certainly enjoy all of this. I find it fascinating.
Well, you do it very well. And we have a doctor watching named Dr. Daryl Woodruff says, this is the best presentation I've seen in a very long time.
Oh, thank you.
Yeah. I mean, I hope you didn't spend too many hours preparing for it, but you do a wonderful job explaining this. Do you mind taking a couple of questions from the viewing
Sure.
audience? Thank you, Dr. Rogers. Susan asks, can you tell us if gadolinium injected for contrast MRIs is dangerous?
Well, I personally think that it depends what you're going for. What's the reason for the MRI? If there's a very good reason for the MRI that the gadolinium is going to be helpful, then it's good to give it. Like, let's say a patient had cancer. They want to know if they've got brain metastases or liver tumors. Then the gadolinium is very helpful to see it. On the other hand, though, if a patient's just getting a routine follow-up, like let's say they've had a known multiple sclerosis or a known acoustic schwannoma of cranial nerve 8, then I would say you don't need it. I can tell what's going on without the IV contrast. Most of the time in the spine, I can tell without the contrast. So I do think it has some potentially minor harmful effects, and it does potentially accumulate in the patient. I've seen patients who've gotten followed up, let's say for 20, 30 years for some chronic problem, and I'll see gadolinium that has persisted in their brains. We don't yet know if that has a clinical significance and impairs their cognitive function or not, but it would certainly be preferable to not have it there. And so what I'm basically saying is I would not give IV contrast unless there was a real good reason.
Thank you. Here's a nice comment from a live viewer. Dr. Rogers presents much concentrated information in a clear way that anyone can understand. Bravo.
Thanks.
Yeah, and he's coming back on August 7th. Here's another question from Susan. Dr. Esselstyn states that toothpaste with fluoride destroys nitric oxide. How quickly can nitric oxide be produced on a daily basis if fluoride toothpaste is used only at night?
Well, at nighttime, our saliva production goes down. So you want your teeth to be clean before you go to bed. But my personal feeling, I don't even use toothpaste. I spent a while trying to read all the different toothpaste, Tom's of Maine, no fluoride this, no fluoride that, no sodium lauryl sulfate. And the conclusion I came to was I tried the salt toothpaste. The conclusion I came to, and I've read a bunch of stuff on dentistry, is you can't win with toothpaste. They all got what I would consider harmful chemicals in them. So what do? First of all, I don't eat sweets. It's mostly sweets and acids that cause cavities. So that would be things like soda pop. It would also be, sweet things. So I would not eat those at all. You got to watch out for is orange juice. Orange juice is really acidic. And so because you have decreased saliva at night, I would definitely floss at night. During the daytime, those little dental brushes are a quick way to clean your teeth out. After every meal, it's good to rinse your mouth with water. And I still will brush my teeth with a toothbrush, but with no toothpaste. The reason I'll brush with a toothpaste is you can form biofilms on your teeth and bacteria can hide in there. They're like the Streptococcus mutans. And what they do is they want to produce acid and that will erode the enamel of the tooth. So you're sort of brushing off those biofilm membranes. You're cleaning out the space in between your tooth. I floss at night with the floss. I use unwaxed floss. You want to use unwaxed because you don't know what they're putting into the wax there. And I know I saw your guest, Nathan Bryan. That was interesting when he talked about not using mouthwash. I'd agree with that. So basically that works well. I don't have any problems with my teeth, and people who do that don't tend to have a problem with it. And if you also, there's a long story, Weston Price. Yeah, I know he was a little bit pro meat and that's not good. He died of a myocardial infarction in 68, but he also, he was right that a lot of these traditional communities that aren't eating sweets and refined flour, they don't have cavities. Very few. So there's something to be said for that as well.
Absolutely. Sherry says, when it comes to fat, do avocados count?
Well, I think plants fats, they come in a better package, if you will. Animal fats, there's nothing good about them. And it also depends on a person's health risks. So if you're a really healthy person and very low risk, it's not a big deal to eat a little avocado or nuts. But if you've got any problems with coronary artery atherosclerosis, stroke, impotence, or you have high dietary lipids, or you're trying to lose weight, I would recommend avoiding all those things. They got a lot of fat in them. And I think fat is fat. A little here and there, because also avocados in the real world are a seasonal thing, just for a couple of weeks, rather than nowadays, every food's kind of available almost all year because of grocery stores and transport systems for modern food.
Absolutely. Thank you. Once the spine is damaged, can it regenerate itself with a healthy diet?
Well, I think what's going to happen is if you exercise, you're going to improve blood flow to the spine. First of all, you'll get better blood flow just from walking. A lot of patients say, oh, I got back pain, I can't do anything. Well, if you can walk, walking is going to get better blood flow to that spine. You get that milking action that's going to sort of get the nutrients into the disc and get the waste products out. It'll increase endothelial nitric oxide within the end plates. In addition, when you switch to eating a plant-based diet, you get better blood flow for multiple reasons. Number one, you got more potassium, you got more magnesium, you got more nitrates, precursors to endothelial nitric oxide. You go out in the sun, you're going to get more nitric oxide, and you're going to reduce your intake of sodium when you start avoiding processed food. So all of those things are all going to improve blood flow, and that's going to improve the way your spine feels. Because the discs are innervated, for example, the end plates are innervated, and there's going to be less, anything that's in there that can heal is going to be more likely to heal. In addition, you'll lose some fat out of your spinal canal, your epidural lipomatosis. So symptoms are likely to improve. I can't always guarantee they're going to improve because sometimes some people are just unfortunate. I mean, I've looked at many, many thousands of spines. Some people just got a tight cervical spinal canal, a developmentally narrow canal. And if they've got severe central stenosis with cord compression, it might be hard to change that. There are some patients who really do benefit from surgery. But what I'm sort of saying is the most common garden variety spine I see is multi-level degenerative disc disease with DISH and, occasionally with OPLL as well.
Great. Thank you. All right. Judy says, I'm on an estrogen blocker with my LDL now elevated, which is driving me crazy because I'm whole food plant-based. Why does this happen?
Okay. Let me hear that one again.
Okay. I'm on an estrogen blocker.
Okay.
With my LDL now elevated, which is driving me crazy because I'm whole food plant-based. Why would this happen?
Well, whole food plant-based is not the same thing as being low fat necessarily. She still could potentially be eating the high fat things like we talked about, avocado or nuts or seeds or oils. Some people have to be more restrictive in their diet than others. They're just more prone to high cholesterols and they're more prone to those types of issues or weight gain. In addition, it's been the experience, I've heard Dr. Esselstyn talking about this, I've heard Dr. Dean Ornish talking about this as well, that patients who follow a very good diet, even if they have slightly higher levels of blood cholesterol, they tend to be very healthy. They tend to get what you'd expect from that diet, even if their blood cholesterol levels are a little higher. I don't know if it helps. I know that animal protein also raises blood cholesterol. That's been shown multiple times, and Dr. T. Colin Campbell especially emphasizes that. I don't know if it would help. Beans have a lot of protein, about 25 to 30% protein, but it's different. It tends to be lower in methionine, lower in lysine. I don't know. I don't want to say something that I'm not sure of, but that would be something I would maybe try is maybe lowering my intake if I'm eating that. That's sort of like the highest plant food in protein. See if that makes a difference. I don't know if it will.
Great. Thank you. How do you feel about dental x-rays?
Well, I would recommend minimizing that. Dental x-rays have improved over the years that they're better collimated. So you're going to get less radiation to your brain. And so they're pretty good. If they come in from the side with a small, good camera, it's probably not going to take too much. But one of the great secrets of health is what you really want to do is avoid all these problems. If you take really good care of your teeth, you don't have any soda pop, you don't have any orange juice, you floss your teeth at night, you brush them with a plain brush, you rinse your mouth with water after every meal, you should never get any cavities. But let's say you still have a problem. Because what I'm trying to say is a lot of people are convinced, I've got to go for my checkup. And what I'm trying to say is, you look at these people in the, Dan Buettner's National Geographic Blue Zones and other really healthy populations. They're not always going to the doctor or the dentist to take care of themselves. They just have good health habits and they don't have a problem. So what I'm trying to say is the best thing you could do is do everything in your own self-control and power to optimize the health of your mouth and only go to the dentist if you have to. Now, I realize there's some people who would see that differently. I know there's some people who say, a lot of dental disease is asymptomatic. And there's also some people who say, most coronary artery atherosclerosis is coming from dental disease. I don't personally believe that for the reasons like I just said. You could cure coronary artery atherosclerosis by lipid reduction. That doesn't have anything to do with bacteria. You don't have to give antibiotics to anybody to cure their atherosclerosis. So what I'm basically saying is if you have to get the x-ray, maybe you have to get it. And they are a lot better now. So they're probably not going to, and just mention that to them, that it's coming in from the side and it's going to have a small film and it's a good, relatively modern camera. It's probably a pretty minimal thing. But all I'm saying is I would not volunteer for it. Just to give you a little perspective, I haven't been to a dentist in 25 years. I just take care of my teeth. They're fine. I don't need to go to a dentist.
Wow, amazing. So question from Rachel. Do you ever see liver cysts go away with getting rid of fat from the diet?
I have not seen a liver cyst resolve, but the typical liver cysts, they're very common. We don't know why they happen, but a liver cyst by itself, it doesn't matter. An isolated benign liver cyst, let me put it this way. I've seen many thousands of them, and I've never once seen any of them turn into anything. Okay. When you first diagnose a liver cyst, you might not know for sure it's a liver cyst. Usually you can tell pretty well, but sometimes you might not know. And if you don't know for sure, you might want to follow it, see if the patient has any other risk factors. Like if they have a known primary malignancy, and that's the first set of imaging, you might watch that cyst extra careful. But I can tell you a garden variety liver cyst, super, super common. I've never once seen any of them turn into anything. So if it's been shown to be benign, then I would just forget about it.
Thank you. You know, I'm looking at your Amazon page and you have quite a few books, and somebody's asking which one would you recommend that's most focused on diabetes?
Okay, well, the way I wrote them was, first of all, I was kind of like learning how to do it, and I had a lot of fun doing that. But I think the most fun book was A Tale of Two Toes in a Hot Tub. I basically wrote that book to make my friends laugh, okay? And it's a spoof on Jonathan Swift wrote a book, A Tale of a Tub. And then the subtitle is the key thing that tells you what the book's about. It's how to improve blood flow. So that's a good entry-level book. And kind of the way I write is I know I sometimes go into some complicated technical things. So I try to have a couple of jokes to kind of amuse the person and make them willing to stick with, you know, reading about the physiology. So that's a good introductory book. And then the next one I wrote after that was Hot Topics in Nutrition. And these books will get progressively more complex. I'll go into some significant amounts of biochemistry along the lines of what I went to in this talk. I actually went into more diabetes, biochemistry, and physiology in this talk than I've had in my books. I do go into, in one of my books, How to Reduce Risk of Chronic Disease. I go into quite a lot of biology of complications of diabetes. But in terms of, I kind of wrote a trilogy here. So A Tale of a Tub, How to Improve Blood Flow, that's number one. Number two would be Hot Topics in Nutrition. And that's going to be more and more specialty topics in nutrition and health. And then the third one after that was Journey to Optimal Health. And that's one where I go into all the ion pumps and really a lot more advanced physiology. I go into different mechanisms of neurodegeneration, things a person can do to reduce the risk of dementia. But I would say all-purpose books, probably the two most people would find interesting with regard to nutrition would be Tale of Two Toes in a Tub, and then Hot Topics in Nutrition.
Great, thank you. How harmful is the fat that is vaporized from cannabis? I didn't even know that I don't know anything about drugs.
I would stay away from all that stuff. I think cannabis has significant harmful effects on brain function, and I would avoid it. I would avoid it very much so. That'd be my personal, what I would do. Yep. I think it potentially, there's a lot more about it. And I have a lot of friends and neurologists, and they send me patients, and that tends to be the opinion of the neurologist, you know, when we talk to each other as well.
Yeah, thank you. It's nice to hear a doctor speaking honestly about things. You know, most doctors will tell you, yeah, it's okay. Alcohol's okay. That's what I like about you. You tell the truth. And I would like to thank Susan for her super chat donation. And she has a question. Are oranges as bad as orange juice?
Well, I think it's good to eat orange juice. Orange juice are better, especially, you know, be careful that they don't spray anything on them. You know, sometimes they spray a lot of stuff on the outer surface of orange, and it's kind of hard to eat an orange. You know, you got to get your mouth on there. And so if they spray something on the outside, you sometimes get like an irritation on your lips, or it'll smell funny. If it smells funny, then yeah, don't buy it. But if it's an organic orange, go ahead and eat them. I think there's a lot of healthy things in orange. In addition to a lot of vitamin C, you know, it's a healthy plant food. So I think it's a good food. And I think you could, if you make it home squeezed, that's probably pretty good. But, you know, anything store-bought type of orange juice is going to be hyper acidic. And, you know, they always taste the same. Anytime a food stuff always tastes the same, you know, they're probably putting something else in it. I'm not a fan of store-bought in that sense.
I hear you. Do you ever see gallbladder polyps go away by getting rid of all the fat in the diet? Asks Rachel.
I have not personally seen that, but usually what I go by for gallbladder polyps is size criteria. If it's 5 millimeters, if it's less than a centimeter, you know, some of the books will say you don't even need to follow it. Usually I'll tend to follow a gallbladder polyp if it's between 5 to 10 millimeters, at least get 1 or 2 follow-ups on it. I can tell you I've seen hundreds of gallbladder polyps. I never ever seen them turn into cancer. You know, every doctor is always scared of being sued, so they're extra careful. But you show me a small gallbladder polyp, I never seen one of them turn into cancer. So especially the size would be the main thing there. If it's If it's less than 5 millimeters, forget about it. It's next to zero risk of malignancy. If it's in that range of 5 to 10, maybe 1 or 2 follow-ups at 6-month intervals will be reasonable.
Thank you. Do you worry about liver hemangiomas?
Liver hemangiomas? No, hemangioma is a benign tumor of the liver, and people will have them their whole life. Once you got one, it'll be there your whole life. It's not a big deal. There's very rare exceptions. There is such a thing as a giant hemangioma. That would be like 1 out of hundreds of them, where it's on the edge of the liver, and you'd worry, well, could that rupture or something? But that's rare stuff. The garden variety hemangioma is just a benign one. It'll have some intact liver capsule around its outer margin that protects it. So like I said, the giant hemangioma with no normal liver tissue between it and the peritoneal cavity, that would be the rare type at risk for bleeding, but super, super rare. Have I ever seen that? I seen that once in a conference when I was a resident, preparing for boards exam. Okay, that's how rare that is.
Great. How do you reverse non-alcoholic fatty liver disease?
Well, you got to minimize dietary intake of fat, and you also got to watch out for things that are converted to alcohol. So that are converted to fat. Alcohol, for example, 2 carbon units, ethyl alcohol, that's rapidly converted into fat. So I would recommend don't drink any alcohol at all. The second thing you got to watch out for is fructose. Fructose is a tricky sugar. It is not the same thing, especially industrial fructose. The amount of fructose in fruits that comes packaged with the fiber and all the antioxidants and stuff, it's pretty healthy. But watch out for like liquid fructose sweetened beverages, because you could guzzle tons of fructose very rapidly. And it's not like glucose. Glucose goes throughout the body. Every cell in your body is made to metabolize glucose. Fructose goes straight to the liver. It's metabolized like a toxin, and the liver then takes it and it enters glycolysis at the 3-carbon phase, like where DHAP and glyceraldehyde 3-phosphate are located. And the relevance is that is beyond the regulatory step. The key regulatory step in glycolysis is at phosphofructokinase. All right. So the liver only runs glycolysis when it needs to with glucose. But fructose, when it hits as a bolus in the liver, it just runs to the end of glycolysis, turns into pyruvate, tries to get in the mitochondrial matrix to go through Krebs cycle, but the liver says, hey, we don't need to be burning this for energy. So it comes right back out of the matrix and it gets made into fat. All right. Because it started out as a 3-carbon unit. You're going to decarboxylate it, make it into an acetyl-CoA, and it's going to get made into fat. So it gets made into saturated fat. Typically, it gets made into palmitic acid, C16-0, and that's saturated fat. So you don't need that. And then you get a fatty liver, and you also get more fat released into your blood, elevated blood triglycerides.
Terrific. Let's see if there's any more questions. Wow. Well, this has been amazing. What can I tell you? They did some research at PCRM to reverse non-alcoholic fatty liver disease with a plant-based diet, Dr. Hannah Kalyova, and it is published in the medical research. If you wanted to see it, I could send it to you. Well, you are just an encyclopedia, Dr. Rogers. I really enjoy your presentations very much, and they're the kind that you really have to watch more than once to glean all the nuggets of wisdom. So thank you so much for coming on the show, and I look forward to seeing you back on Sunday, August 7th.
Yeah, well, my pleasure. Thank you.
Okay, take care. And thanks all of you for watching another episode of Chef AJ Live. Please come back tomorrow when we'll continue talking about diabetes with Dr. Stefan Esser.